Okay. Hello, everybody, and warm welcome to European Sepsis Alliance 7th annual meeting here in Brussels. We welcome all of you who are here in Brussels, but we also welcome all the people who are joining us online from all over Europe and the world, really. I would like to start with welcoming up Evangelos, who is the President of ESA, European Sepsis Alliance, to just give us some opening remarks. I'll go down here. Sorry.
Thank you very much, Ulrika. And I would like also to warmly welcome you to this 7th annual meeting of the European Sepsis Alliance, and which is taking place one more year in Brussels. And I'm really happy that for the first time I see new faces in the audience and also fresh young people, and this gives me a lot of enthusiasm to continue this struggling for sepsis. So I would like in the next 5 to 10 minutes to explain you what the European Sepsis Alliance is about, which is the steering committee, and what is our aim. But before this, I would like to tell you about my motivation of being a physician who's actively working in the sepsis field. So my name is Evangelos Giamarellos. I'm the current president of the European Sepsis Alliance. And I remember for the first time, this is when everything started for my career, it was back 26 years, 1998. I was a fellow in internal medicine. And I remember a young father of 48 who was at a delirium. You know, at that time, technology was not that evolved, and it was very easy to say, give him a sedate. Let's stop this. It's easy. For some reason, I approached the patient and I realized he was feverish. That was really remarkable. He had 39 degrees. And then everything changed. We realized that this patient has a renal abscess. And unfortunately, 32 days later, he died. And then my question was, he got the correct antibiotics. The antibiogram revealed an E. coli was susceptible to the antibiotics the patient was receiving. We did the puncture at time 0. We removed the pus out of his body. Even 10 days from symptoms onset, he had nephrectomy. Yet he died. What went wrong? 26 years after, many of these questions persist. And despite new technologies, despite all research efforts, we still discover more and more mysteries and unknown and untold stories. There are two options in my point of view, and this is the point of view of the board of the European Sepsis Alliance, to combat sepsis. The one is the traditional way that you need physicians, you need researchers, you need people who are doing that and who know all literature out there, how to deal with research, blah, 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 blah. But this is not enough. Because medicine is an art, and medicine needs to be focused on the needs of the patient. If we stay on the research approach, if we stay on the technology approach, then we have lost the fundamentals of medicines and of humanity. And as I'm coming from Greece, these are the teachings that I remember from my first day at the Athens Medical School of being told by my tutors. And there is a lot of suffering. And unfortunately, it seems that our physicians, as the time goes on and we are growing up, we are losing an emotional way of thinking, which is something fundamental to the combat against sepsis. That's why the principles of the European Sepsis Alliance and of the Global Sepsis Alliance is to bring together patients to help us, to teach us, and all together we need to approach something bigger. You have seen, just before the pandemic, there was a publication at Lancet that almost 50 million people every year suffer from sepsis, and 11 million of them die. How many has suffered so far from the pandemic? Altogether, 3 years, far less. How many have died from the pandemic all these 3 years? Far less. And why journalists, politicians, everyone likes to talk about the pandemic, the Twitter, the Facebooks, and all these communication tools, and nobody about sepsis? Because it's difficult, because it's tough, because there is complexity, and people, they hate complexity. That's why the reason of being at the European Sepsis Alliance is because we are in need of the alliance, not of people specialized in something. We are in need of all those who understand the burden of the problem, the dimensions of the problem, and the overall burden of the society. As physicians, we cannot understand everything. We just think the patient was admitted, the patient was discharged. And what after that? So we need the help of all of you. And the steering committee, which the last years are struggling day and night on that, is asking that you embrace our task and our goals and our aims. With a lot of enthusiasm, I see that as the time goes on, we become more and more known, we expand the concept, and the last year we managed for the first time to have webinars to combat antimicrobial resistance. This year we have a big scientific achievement, a postgraduate course which is co-organized with the European Society of Clinical Microbiology and Infectious Diseases, and with the task to combat antimicrobial resistance. It takes place on the 25th, 26th, and 27th of September in Athens. I welcome you all in this conference, and I'm looking forward that this day, for all of you who are newcomers, is just the beginning of a long, sustaining collaboration. Thank you very much.
Thank you, Evangelos, for this. We were supposed to have an opening speech from the new CEO of Global Sepsis Alliance, but she's running a little bit late, so we are changing a little bit in the order here. So we're going to have a video recorded message from Hans Kluge, who is regional director of the WHO here in Europe. And he's going to talk a little bit about the strengthening the sepsis strategy at European and global level. Marvin, are we ready to go? Okay, so over to Hans Kluge.
Ladies and gentlemen, esteemed colleagues and distinguished guests, amid the many health challenges facing us in the WHO European region and beyond, sepsis remains an impressive adversary in the global health landscape, with recent epidemiological findings underscoring its pervasive impact. While our previous understanding highlighted the magnitude of sepsis, ongoing research and surveillance have continued to reveal its persistent threat and the dynamic nature of its epidemiology. It is estimated that every minute more than one person dies from sepsis in Europe, and 3/4 of the 2.8 million survivors face long-term sequelae. These dramatic data demonstrate the magnitude of the challenge. Despite advances in infection control in recent years, the burden of sepsis has not waned, continuing to affect millions and millions of individuals across all age groups, with a disproportionate impact on the most vulnerable populations, including children, the elderly, and the people with pre-existing health conditions. According to the WHO Global Report on the Epidemiology and Burden of Sepsis for 2017, it was estimated that sepsis affected 49 million people worldwide, contributing to approximately 11 million potentially avoidable deaths. Notably, almost half of all sepsis cases, some 20 million, involve children under 5 years of age. Indeed, in 2018, sepsis was responsible for an estimated 15% of all neonatal deaths globally. As I noted, despite advancements in healthcare and disease management, sepsis incidents remain alarmingly high, reflecting both emerging healthcare challenges and persistent disparities. As we stand at the crossroads of health and innovation, at the 7th annual meeting of the European Sepsis Alliance, the question posed to us is both timely and pressing. Is Europe ready to address the global agenda on sepsis? In confronting this challenge, we must equip ourselves with the most recent data and insights to guide our actions. Our efforts through the WHO European Programme of Work 2020-2025, United Action for Better Health, have been significant in supporting member states to address sepsis within the broader context of quality of care and patient safety. Our commitment to improving health outcomes has led to significant strides in sepsis awareness, prevention and management. However, we must acknowledge that the evolving nature of sepsis, compounded by the threat of antimicrobial resistance and the complexities of healthcare-associated infections, requires a renewed and intensified approach. Healthcare-associated infections account for 1 in 4 sepsis cases in hospitals and 1 in 2 in ICUs. And for every 1,000 hospitalized patients, about 15 will develop sepsis as a healthcare complication, with mortality rates ranging from 20 to 30%. This data underscores the critical need for enhanced surveillance, research and health system preparedness to effectively tackle sepsis. A firm commitment with quality of care interventions, assuring patient safety and effectiveness of infection prevention and control measures is of paramount importance. The incidence of sepsis and sepsis-related mortality, particularly in settings burdened by limited resources, highlights the essential role of equitable health interventions and the importance of strengthening health systems worldwide. Europe, with its rich legacy of healthcare innovation and leadership in global health, is uniquely positioned to spearhead efforts against sepsis. By leveraging cutting-edge research, fostering international collaboration, and advocating for comprehensive health policies, we can catalyze significant progress in sepsis prevention, diagnosis and treatment. Our alignment with the Sustainable Development Goals, especially those focusing on health equity, maternal and child health, and infectious disease eradication, further emphasizes sepsis as a critical health issue. Combating sepsis is not only a matter of addressing an acute medical challenge, but also a critical component of our broader commitment to global health and well-being. WHO's response to sepsis, culminating in the adoption of Resolution WHA 70.7, has laid a solid foundation for global action. Yet the journey remains difficult. As we continue to develop guidance, support member states and build partnerships, the insights from recent epidemiological data serve as a call to accelerate action. In conclusion, I hope this meeting can boost our joint work against sepsis. Let us harness the latest data, embrace innovation, and collaborate towards reducing the burden of sepsis significantly. Europe's leadership, expertise and commitment are important to address this global challenge. Together, we can achieve a healthier, safer world for all. Good luck.
Thank you to Hans Kluge. Mariam is still running a little bit late, so we're going to the next speaker, which is Philippe Roux. He will join us online. Philippe is Acting Director for Public Health, Cancer and Health Security Directorate at DG Santé here in Brussels. DG Santé is a part of the European Commission and develops and carries out Commission's policies on food and safety and health, public health. And the topic that you will give a talk about, Philippe, is the challenges for Europe for the next 5 years. That's a big topic, so let's hope you can do something with that. Warm welcome to you, Philippe. Do you hear us? You're online?
Half an hour I'm trying, so I don't know exactly if you hear me. Hello?
Tell him to start. Just talk.
Okay, Philippe, you can start talking. We can hear you.
Okay, that's very nice. Do I get it right that you have a PowerPoint presentation that was sent to you that you can put online?
Say yes.
Yes.
Come over to the middle of the screen.
Yeah, and if you can just move yourself a little bit to the middle of the screen, that would be good for the online viewers. If you can move your head a little bit to the middle of the screen.
What do you mean by to
Uh,
to the middle of the screen?
in the,
I mean,
yeah, that's
very
good. That's
fine,
good.
but-
That's perfect. Thank you. That's perfect.
I mean, you're here for my brain, I hope, and not for my head or face. But I'm so sorry, I see no one. I see you and I see nobody. So I have the impression that I'm talking to me. Is that normal?
That's fine. You can talk to yourself. We hear you.
Yeah, but I want to see you.
I'm sorry. That won't be possible. You have to speak into yourself.
Okay.
Sorry.
Okay. Good. So at least I'll be in agreement with me. So I don't know if the screen, I don't see the slide either. So are they on?
Are they on?
Yes.
Okay. Yep. They're
Because I don't see them either.
see the slides here.
So it's a discovery for me to
Okay.
to work without my eyes.
No, he cannot.
Look at your own slides, and we will change whenever you change.
Okay, no, just okay, sure. No, it's just because I have the impression that I'm alone with 3 participants, so I hope that you all are here. I was very sorry because I was hoping to be able to join from the start so that I could have a bit an idea of you thinking at the moment and where you are. I'm pleased to be here with you, even if it's in difficult conditions with these IT problems, and I apologize for that. The advantage is that I'm able to speak because with the many different initiatives, we have difficulties to follow all the important ones that are going on and to travel all the time. So the IT has advantages, but the inconvenience indeed that sometimes we cannot exchange easy because the technique is behind. So perhaps just to introduce rapidly myself, I'm acting director in this Directorate B in the Commission, which is on public health, cancer and health security. So that is my current position. I'm also actually still head of a unit which is working on cancer and health in all policies, so making my life interesting and busy. And if I can go to the slide on main policy development with that title, that would be great. Because indeed, I think the first thing to say is that sepsis is a serious condition that affects millions of people worldwide. So it's not nothing, and it's very important to mention that it's something that we are very well aware about. and that the EU is supporting a wide range of actions related to sepsis, including on patient safety, antimicrobial resistance, research on infection prevention, and new antimicrobials, of course. And that we have also recent initiative on in the area of IMR, which directly or indirectly contributes to the effort to combat sepsis. So we are in a wider context, indeed very much active in the field. I think what I would want to do in a couple of minutes with you is to make a couple of updates on the recent policy development, which are the most relevant for sepsis. And I think the first is the Council recommendation on IMR, which was adopted in June 2023, so last year. In record times, I would say. The Commission proposal was adopted in April, so you see, from April to June, very fast. So a subject that really was easy in a way to make the member states in agreement. And the funding activities, especially the new joint action on IMR, Giamarellos, for those that, Giamarellos 2, for those that like the acronym, and several projects under the Horizon Europe. And also the international activities more broadly, and that includes, of course, the upcoming United Nations General Assembly high-level meeting on IMR, which will be an important one. So we'll go perhaps a bit through these elements rapidly, if that's okay to you. So if we go to the next slide, with a title on that is 2023 Council Recommendations on IMR. So, as I've just mentioned, the new Council recommendation has been a major policy initiative that has had strong support from the member states, and it is a major latest policy development on IMR, especially in public health. So now our focus is indeed on implementation. And what is important for you to know, if you have not had the opportunity to read the recommendation, is that under its part on infectious prevention and control, the recommendation mentioned explicitly sepsis. And I think that's a very important element, because that means indeed that it is not left aside, but it is really in the heart of the actions that are there being considered. And strengthening infection in prevention and control, especially in hospitals and long-term care facilities, benefits, of course, not only to the fight against IMR, but also against health care-associated infections, which are often a key cause for sepsis. Further areas such as antimicrobial stewardship, prudent use, and access to antimicrobials are relevant also. Fast access to rapid diagnosis to ensure early diagnosis, also very important, as you well know, together with the optimal use of antimicrobial for treatment, are crucial elements also to fight against sepsis. I mean, that's for us very clear. Also, one element which is sometimes a bit neglected is improving awareness and education, in particular, firstly, among clinicians and healthcare professionals. I mean, that may seem strange, but indeed it's very important. And also, of course, to the general public, including on prevention opportunities such as vaccinations, are also part of the Council recommendations. We also could recall that the Council adopted the Council recommendation on patient safety in 2009, which is relevant to the fight against sepsis. I mean, it's not a recent one, but nevertheless, it's an excellent tool in the discussions with the different actors in the member states in charge of health and public health. And the Commission has actively supported the implementation of this 2009 Council recommendation on patient safety, including the prevention and control of healthcare-associated infections. And we produced 2 implementation reports and supported a joint action on patient safety through the EU Health program at the time. If you go now, please, to my next slide on EU EMR targets, that would be great. Thank you for those that are supporting that. I think for us, a novelty, I would say, and of importance of these recommendations is that they include targets. And for the first time in IMR, in human health, we have targets, and that's very important. And we have similar targets on animal health side under the farm to fork strategy, because of course we here are trying to actively work in the context of One Health, so that's important also to mention here. And 2 of these targets are to optimize consumptions and thus reduce the misuse, overuse of antimicrobials, which is considered the main driver of IMR. And 3 of these targets are to control the incidence spread of the main critical pathogen in the EU, Staphylococcus aureus, E. coli, and Klebsiella pneumonia. The baseline for all these targets is 2019, and the target year is 2030. A first report on the progress was published by ECDC last November, showing that what work remains to be done. But as you see, it's not a recommendation, but there is also the volunteer to really ensure the monitoring and the review of progress and ensuring that we are heading in the right direction for achieving by 2030 the results. The EU level targets are of course broken down by member states, where each country target is supposed to contribute to the fulfillment of the all EU targets. Because of course, like in many domains, I mean, not all member states are at the same level and at the same path. So this is the reason why we approach it this way, and I think it's a very efficient way to proceed. I don't know what your opinion would be on that, but really, I think taking into account the reality of each country is an essential element. If you couldn't go now to the next slides, and I promise there is not many slides more. The one on which is entitled follow-up to the new council recommendations, please. So as I said, in addition to the overall monitoring of the targets, the Commission is mandated to, in the council recommendation, to work on the guidelines on infectious prevention and control together with ECDC. And those would be, of course, pertinent also to sepsis control, as mentioned earlier, given the key role of hygiene and prevention of hospital-acquired infections play. So that's clear. Also on guidelines on antimicrobial stewardship for the treatment of major infections, which is the main, with the main idea to ensure that common illnesses such as sore throats or urinary tract infections are treated prudently across the EU, as there should not be medical reasons why patients in one country should receive stronger antibiotics than in another. So the work on this is still in the preparatory phase, but worth to mention. And of course, we are also strongly contributing to communication effort to raise awareness, and we will be producing a report on implementation of the Council recommendations by 2027. If you go to next slide on funding. Again, I mean, funding is also an important dimension. As you know, money helps achieving, and we have seen this the boost that was possible thanks to the EU for Health bigger budget that we have had, allowing us to invest more in key actions. So the recommendation provides the main intentions for strengthened efforts over the next years. In human health, the prerogative for action in health remains with the member states, as you know. So we are here to support. We cannot act directly, but the EU level, at EU level, we have mobilized our instrument to provide a sizable investment to support the national action through the funding program. And two of them, of course, that you certainly well know already, the EU for Health and Horizon Europe. So under the EU for Health, there are several major projects running, which indirectly contributes to the fight against sepsis, and as they are related to IMR and the health care associated infections. We have mentioned some example on the slides, so I will not repeat what you can see. But I think that the most important for us is a joint action Giamarellos 2, which is the biggest investment at EU level on IMR to date, with an overall budget of 62.5 million euro, and of which 50 million from the EU for Health budget. For comparison, I mean, just to because that's exemplify what I said before. I mean, the first time joint actions had only 4 million of EU confunding, so confunding. So you see what was possible here, and hopefully that is for the good and lead to more impactful results. Sorry. So this second round of Giamarellos contains work packages on infections, prevention and control, stewardship and access to antibiotics, which all are crucial to limiting the spread of resistance, treating patients effectively and limiting secondary health-associated infections. So to find the right balance, which, as you know, is very essential. Next slide, which is the before last one, funding on Horizon Europe. I think one of the novelty in terms of actions also during this commission has been the core work, or the, how could I even say that? Really, the joint effort between these two tools and with the two DGs in charge, so RTD and DG Santé, to work together and to try to reinforce each other. So in this context, under our Horizon Europe, there are several projects which concretely add value on sepsis, and we have something like 35 million invested in research, and 4 of them, I think, are on the slide, which hopefully you can see. So in addition, there are projects on IMR, which exceeds 300 million in funding to date in the first years of the program. So reasonable, important investment here again to ensure that we make progress on research to the benefit to the fight against sepsis, and especially efforts to improve diagnostics, early diagnosis, efforts also to bring to the market no antimicrobials, etc. Now, last but not least, I would say, with the last slide on international policy development, important to mention that our efforts are not only domestic, but also globally, because as you well know, the IMR and infectious diseases do not stop at borders. I mean, we have learned that if for those that didn't know that, have learned it the hard way with COVID. So concerted action is really necessary internationally. So that's for me very important. And on this international front, the EU continues to be a strong proponent for concerted global action on health threats, including IMR. So we have collaborative efforts that are taking place in multilateral fora, such as the G7, the G20, and last but not least for me, the Transatlantic Task Force on Antimicrobial Resistance, where we are very actively exchanging with colleagues from not only the US and Canada, but at large on antimicrobial resistance approaches, development, research, and progress made. So another, I think, major development is the ongoing negotiations on the new pandemic agreement and the revision of the international health regulation, where we are hopeful for a constructive, positive and constructive outcome. I mean, discussions are, of course, complex and complicated, but I think the volunteer and the EU member states and the Commission, we're working together hard for making the best possible outcome of it. And the last element, perhaps, which is not the least, is the upcoming United Nations General Assembly high-level meeting on IMR in September this year, which will be a pivotal event, I think, which should galvanize political momentum on IMR. And the EU would be keen to see agreement on concrete commitment, including targets, because always, I mean, without targets, it's, let's say, wishful thinking. And we are very in favor of having effective outcomes with strong targets. And I would finish by this. Thank you very much for your attention.
Thank you so much, Philippe, for joining us online. Although you can see
since 2004, my political life has been marked by trying to achieve impactful legislation and initiatives to improve our society. For example, the law Muylle-Vandenbroucke, who introduced a smoking ban in hospitality venues, and also the recognition of clinical psychologists are some of my milestones in my career. Within the Committee on Health and Social Affairs, my focus has been on the organization of hospitals in Belgium, healthcare professions, and also the Belgian labor market. I was also, during the COVID-19 period, Minister of Labor and Economy here in Belgium. In the Health Committee, I'm working closely with my colleague, Robbie de Calloway, to make sepsis a top priority in our national health discussions. Our joint efforts began with a roundtable discussion on sepsis and led us to co-authoring a significant resolution in 2021. This journey to put sepsis at the top of our national health agenda has been, for me, a personal but also a political one, driven by the tough realities of sepsis and how it affects individuals and families. This became even more apparent for me when I met Ilse Malfait, whose story was deeply moved me and fueled my commitment. She showed me that our mission goes well beyond politics. It's a heartfelt fight for all those silently suffering. Because despite its high death and illness rates, sepsis is still not given enough attention in Belgium and so many other countries. Bringing sepsis onto the agenda of the Ministry of Health in Belgium has not been easy, to say the least. This journey has been marked by the struggle to gain recognition for sepsis within our healthcare system and political landscape. Despite its severity, sepsis has remained an under-recognized condition, often overshadowed by more visual health issues. Why is it so crucial? It's more than just ticking another box on a long list of health priorities. It's about tackling a widespread threat that can arise from simple infections. Sepsis doesn't choose its victims, and it does not discriminate. Anyone can be affected, young or old, healthy or unhealthy. Our goal is to effectively integrate sepsis management into our healthcare policy. This includes implementing a national plan with action points such as data collection, educational campaigns, the establishment of a sepsis network, guidelines for early diagnosis and treatment, continuous education for medical professionals, and specialized post-care and rehabilitation for patients. Moreover, we stress the importance of incorporating sepsis awareness into the curriculum for future healthcare professionals. By prioritizing sepsis, we are taking decisive steps toward quick detection, effective treatment, and most importantly, prevention. This also includes training healthcare workers, raising public awareness, and crucially supporting research to fight this condition more effectively. Facing these obstacles, like a complex political environment and a critical lack of sepsis awareness and data, has been challenging. In Belgium, like in many other countries, precise sepsis data on sepsis is hard to come by, underscoring a global challenge in surveillance and reporting. Lacking detailed data makes it tough to convince stakeholders. The same shortage of information also makes it hard for us to fully understand how sepsis truly affects our healthcare system and society. Another significant challenge has been breaking through the inertia. Despite its devastating impact, sepsis isn't viewed as a pressing new issue and struggle to gain attention amidst another emerging health crisis, especially in a post-COVID-19 period. Despite the obstacles we face, progress is being made. in the fight against sepsis in Belgium. Initiatives aimed at raising awareness among healthcare professionals and the public with the broadcast on national television pushed the Minister of Health to action. I'm really grateful that our Federal Minister of Health, who has recognized the importance of our efforts and is actively now working towards a comprehensive sepsis plan. His collaboration with experts, including also Professor Ulrika Knutsson and representatives from Sepsibel, is promising. As part of this collaborative effort, several working groups have been commenced a literature review and an assessment of the situation. This month, recommendations will be formulated with the ambition of finalizing a document by the end of April. The timeline set by Minister Vandenbroucke, aiming for a final document in April 24, is a testament to our shared commitment to addressing sepsis effectively before the end of legislation, of this legislation period. And yes, we have elections in June, and we will further in Parliament. Also, during the period after the elections, we can prepare laws, we can prepare a lot of things. When Parliament in September, October starts, we are then in a caretaking period, but also in a caretaking period, we can take initiatives. So he already took the engagement, Minister Vandenbroucke, to work on it after the elections. So it's a yes. Reflecting on this journey, I'm also inspired by the resilience of those affected by sepsis and the dedication of healthcare professionals and the potential for change when we come together for a common cause. And especially Ilse. Thank you, Ilse, for sharing your story and putting sepsis on the national agenda in Belgium. You did it. Your strength, yes. Her strength and advocacy are really a beacon for inspiration for so many. I'm sure that with a collective effort, fueled by political determination, expert knowledge, and heartfelt stories from individuals like Ilse and many others, that emphasizes our commitment to confronting sepsis. We do it with only one mission: saving lives. Thank you.
Thank you so much. And I'm glad to hear that it was a yes. There will be something coming after the election too. That's very good to know. Now we are jumping back in the program really. Joining us today is the new CEO of Global Sepsis Alliance, Mariam Jashi, who will talk a little bit about the Berlin Declaration, but also renewed global agenda for sepsis. So please welcome Mariam.
Good morning. It's a pleasure to meet the esteemed colleagues, friends, and the co-fighters for the global sepsis agenda. Honorable Muylle is the former member of Parliament of Georgia and the chairperson of the Parliamentary Committee. We would be delighted to share with you the existing network of global parliamentarians network working on the global health agenda. That could be a wonderful platform for sharing Belgium experience and expanding to other partners. In my current presentation, I would like to recap some of the successes of our joint fight and the Berlin Declaration that has been the foundation for the roadmap, the common roadmap, as well as the ongoing work on the 2030 new global agenda for sepsis. As a recap, as you are all aware, Professor Konrad Reinhart founded the organization, the Global Sepsis Alliance, 14 years ago, and one of the foundational achievements of the GSA efforts, together with its regional sepsis alliances and the member organizations, was the 2017 World Health Assembly resolution for sepsis. The global burden of sepsis routine administrative health statistics definitely hinders the stronger engagement in the global sepsis response. WHO issued the first ever global sepsis report also in 2020. The GSA has established 4 regional sepsis alliances, including the European Sepsis Alliance, the Asia-Pacific, African and Eastern Mediterranean, and we're closely collaborating with Latin American Sepsis Institute that was formed earlier than the GSA. The World Sepsis Day movement since 2012 has engaged over 45,000 stakeholders globally, and the World Sepsis Declaration, also authored by the Global Sepsis Alliance and its partners, has been signed by 14,000 stakeholders. Despite the efforts, this is our reality. 48.9 million people affected by sepsis every year, including 13.66 million deaths every year. Those are the latest estimates from the Institute of Health Metrics and Evaluation based in Seattle University, and the 48.9 million annual cases are also officially recognized by the World Health Organization. Sepsis is causing 1 in every 5 deaths globally. And the majority of the excess, almost 50 million excess deaths during COVID-19 were related to viral sepsis. So, the 5.1 million deaths from sepsis are originating from non-communicable diseases and injuries. So, against the initial thought that only infectious diseases were leading to sepsis, the contrary has been already documented. And sepsis is also bearing a major economic cost, both to healthcare sectors, taking to almost up to 3% of the healthcare expenditures and 0.33 gross national products. The global sepsis response is essential if we are serious about attaining 2030 health-related sustainable development goals. If we are ambitious of attaining universal health coverage targets, or antimicrobial resistance, or the pandemic preparedness, prevention, and response agenda, we have to strengthen the global sepsis response. However, the reality is that we have disproportionately low attention to sepsis versus its human and economic burden, and less than 10% of the UN member states are prioritizing sepsis in their national health agenda or implementing the World Health Assembly resolution. And when we speak about the disproportionality of the political attention, this slide is critically important. Every health minister today, every politician speaking about the global health, they know that antimicrobial resistance causes is associated or attributes to 4.95 million deaths every year. But almost none of the politicians know that this 4.95 million originates from the same study of the Institute of Health Metrics and Evaluation, that the 4.95 million AMR-related deaths are part of the 13.66 sepsis-related deaths. And this is the key slide. When we hear from honorable colleagues, directors of health, our fellow politicians, that AMR is the priority, sepsis is the umbrella problem where 5 million deaths are associated or attributed to the AMR. So that's why in the current global health dialogue and architecture, we cannot continue the status quo. Sepsis should be positioned in the global health agenda and the mainstream of the global health architecture, and that is the vision of the Global Sepsis Alliance. When we speak about reinvigorating the global sepsis agenda, one of the main documents that was launched in September last year is the Berlin Declaration on Sepsis. That is a very succinct summary of the successes, challenges, and the way forward for the global community. The document has been already signed by 75 international organizations, including the World Health Summit and the Clinton Health Access Initiative. Following the Berlin Declaration, we had the first ever high-level sepsis side event on the margins of the UN General Assembly last year, and the Global Sepsis Alliance and the German Sepsis Foundation were joined by the Unite Parliamentarians Network for Global Health, Clinton Health Access Initiative, the Global Antibiotic Research and Development Partnership, Virchow Foundation for Global Health, and the Medical Women's International Association. Those 7 partners made the history of convening the first side event on synergizing sepsis agenda with AMR and the pandemic accord. And as mentioned, the Clinton Foundation and the Virchow Foundation have been our main partners who have been supporting the global sepsis agenda. And the Virchow Foundation, that is literally the Nobel Prize for global health, has made the Global Sepsis Alliance among its main partners. And we definitely are extremely appreciative of this support. The New York UNGA side event was followed by the first World Health Summit side event on sepsis. And on this slide, we have 6 members of parliament from Germany, France, Ukraine, Moldova, and North Macedonia. And of course, our vice presidents, our amazing sepsis survivors, and our Global Sepsis Alliance joining the meeting. In January, I had the honor of representing non-state actors at the WHO Executive Board and to make 2 statements on the urgency of prioritizing sepsis. And we have an extremely reassuring feedback from WHO on the stronger collaboration with Global Sepsis Alliance and the regional sepsis alliances for prioritizing sepsis in the mainstream of WHO work. And as you are aware, by the end of this year, WHO will be issuing the clinical management of sepsis guidelines, and we're honored that the GSA members are part of the review process. The reason I was late today is that I'm directly coming from New York, and just to give you the highlights of 2 very successful meetings with UNICEF and UNDP, we have reassurance of very strong partner readiness for partnership, both from the UN Children's Fund and the United Nations Development Program. Our next step, as mentioned, is the development of the 2030 Global Agenda for Sepsis. That will be the multi-year strategic planning process, will be inclusive of multiple stakeholders. The internal discussion of the document has been already started within the GSA, but the consultation process will continue in April. And the document will be also for partnership and resource mobilization platform. So the draft framework and document is already under development. In April, we will have internal and external consultations, and we hope to have a launch and presentations of the document, both on the margins of the World Health Assembly in May, World Sepsis Day in September, UNGA 79th session of the UNGA and its related high-level meeting on AMR in New York in September, and within the frameworks of the World Health Summit and Unite Summit that currently are co-convened in October of 2024. And the basic framework of the agenda will include both the political leadership platform, how we can ensure that sepsis meaningfully becomes on the high-level political agenda, global health and national health sectors, how we can strengthen health systems response to sepsis, whole of society response to sepsis, innovations for sepsis in terms of diagnostics and treatment, and the global investment case for sepsis that will convince, hopefully, the global decision makers on the urgency of prioritizing sepsis in the mainstream global health talks and relevant allocation of political and financial investments. I thank you for your attention.
Thank you so much, Mariam. We will now have the first panel of today. I'd just like to say, maybe for the people also joining us online, there will be a lunch break at 1:15, so stay put. The first panel will discuss what do health systems need to fill the sepsis gap, and I will leave the presentation of the panelist to the moderator, who is Simone Mancini, who is the coordinator of the regional sepsis alliances here at Global Sepsis Alliance.
Thank you, Ulrika. Thank you very much, and welcome everyone. And I'm very honored and humbled to introduce the panelists of this panel discussion. We will really try to focus on identify what are the priorities and challenges and what are the key elements for successful implementation, for successful prioritization of sepsis in national health system, as recommended and actually urgently demanded by the World Health Assembly of 2017, resolution on sepsis of 2017. So I would like to please welcome our panelists for today, Ilse and Eduardo, Nora, Ron, please come on stage. Thank you very much. Around the presentation, starting with someone actually was already presented and very much known by almost everyone here, our friend Ilse Malfait. Ilse is a double sepsis and cancer survivor, and we are all admirer of Ilse, of her strength and resilience. So now she actually managed to turn her dramatic experience into a story of really resilience, a story of fight against sepsis, and she will tell us more. I just wanted to say that Ilse is she's been called. Someone called her just our star, but actually behind the star there's a constellation, and I want also to praise and greet our friends from Sepsibel and from other sepsis survivors organizations who are actually very much engaged in the European Sepsis Alliance. We have a working group actually who aggregate very engaged survivors who are doing a lot to move things in their country to sensitize the governments and raise awareness about sepsis. So thank you, all of you, for your engagement. Then we have here on my left Nora Luti from Switzerland. Nora is an intensivist and working at the Zurich Children's Hospital, and she's actually the program manager for the Swiss National Sepsis Program. So she will tell us a bit more about the experience in Switzerland and how actually they have managed to involve the Swiss Federal Quality Commission and set up a national plan, and now what are the plans for the implementation. So thank you, Nora. And Eduardo is also Eduardo De Robertis, comes from beautiful Perugia in the middle of Italy, is a professor in anesthesiology and intensive care at the University of Perugia, as well as director of the University Clinical Department of Anesthesia and Intensive Care, and also of the residence program in school in anesthesia and intensive care. So I think you understood his background in anesthesia and intensive care. And also actually we know Eduardo as a past president of the European Society for anesthesia and intensive care, with whom actually the European Sepsis Alliance have collaborated on a number of projects. So thank you, Eduardo, for being here. And last but not least, of course, our friend Ron Daniels from the UK. Is a consultant as the National Health Service and is also very much engaged since quite the beginning with the Global Sepsis Alliance, and is also, which is one of the vice president, and also with the European Sepsis Alliance, being a steering committee member for a long time. And Ron is well known globally in the UK, but globally as CEO of the UK Sepsis Trust, and as he said, is also the Sepsis 6 guy, known as he created the red flag system in the UK. So thank you all for being here. And as I would like to perhaps start with a question for each of you, and we do a first round, and then we continue our discussion, perhaps also try to involve the audience. And so prepare your questions. Ilse, I think your story is always a good way to start a discussion, as you really make it real. We had a lot of impressive figures. We had a lot of quite significant initiatives going on nationally in Europe and globally. But actually, what is really sepsis? What happened to you? And actually, what moved you? I mean, we have heard about this famous documentary that was broadcasted in Belgium. Not everyone watched it, of course, and here outside Belgium, but it was a great success and it really triggered a big movement here. But we would really like to hear from you a bit, and then we will explore more about the national plan that was mentioned by Ms. Muylle afterwards. Thank you.
Thank you for inviting me.
Sorry, I forgot this is the microphone that you have to pass on to each other.
Thank you for inviting me. I survived a septic shock in 2020, and it all started with a small lump in my breast. And 4 days after my first chemo, I stumbled into hospital with severe abdominal pain. I was rushed into surgery. And then the inhuman pain the day after the operation was normal, the doctor said. Within 7 days, you will be home. But the 7 foreseen days became 487 days. I had a septic shock, and they flew me over to University Hospital, where I was in a critical condition for weeks. My family heard for weeks that I would probably die. Thanks to a top medical team, I survived. I underwent 22 operations, the amputations of both lower legs and all my fingers. And they also did a mastectomy because sepsis weakened my heart too much. Chemo was out of the question. And then once back home, after 16 months, I started writing a book to process what happened to me. And also because I was a bit frustrated that I had to explain over and over again to people what sepsis is and what severe consequences it can have. But the first chapters of that book were blank. I did not remember a lot of the first days. And I discovered in my mobile some disturbing messages. I've sent the first day after my operation, I was still on the ward. I've sent in the morning, hell, I'm broke. And then 2 hours later, I've sent to my husband, pain medication is increased, finally. And then in the evening, I sent my last message. I sent problems now, groggy, fainting, nausea, and oxygen deprivation. Pain medications are increased. And I wondered if that were sepsis signals. And I went back to the doctor of the initial hospital, and the doctor said 3 times, I looked at your medical record, and I would react in exactly the same way. For me, that was the turning point. I don't know what I expected to hear at that time, but certainly not the words, I would react in exactly the same way. So at that moment, I started reading a lot about sepsis, and I contacted other Belgian sepsis survivors who are in the room right now. And they invited me to the ESA Congress of 2 years ago. And you gave me the brochure of the ESA, and so I saw a picture who was very confrontational. And it was this picture, the red flag sepsis card. An acute assessment tool, and I could tick off the box of a lot of sepsis signals that has to lead, I read it here, actions to be taken within 1 hour. So I knew that that wasn't the case in in my file. And I started reading a lot about early warning scores. And I wondered if the Muse, for example, and News and SIRS and SOFA would raise earlier alarm in my case. And then I discovered that there has been 33 hours lost before the right medication was given, and it took another 4 hours before I was transferred to ICU, completely confused with an abnormally low blood pressure of 60 out of 44. And then I knew that people die needlessly. I was nearly dead. So at that time, I thought we have to shift up the gear. We heard Mrs. Muylle, the parliaments have made a proposition for a resolution. Other sepsis survivors tried to get attention, but we didn't get any attention in Belgium. So I wrote an email to some research journalists, and the consequence, you know, we had a television program broadcasted by the end of November. And with the Sepsibel Association, we made a PR event around it. We also had the book launch at the same time, the same day. I was in the news, and all the news, nearly in all newspapers. And let's say that it was the first time that we heard a lot of sepsis in Belgian media. So that's my story.
Thanks, Ilse. Then we'll explore more about what happened after. Yes, I think it works now. Thanks, Ilse. Yes, we will hear more about your story and what happened after this engagement, what you triggered and what you guys in Belgium triggered afterwards if we move on. And you mentioned the flag system that from the UK is also interesting. We'll pick it up later as well. I would like now to bring Eduardo in, without putting you on spot, Eduardo, but indeed, from a physician perspective, how could that happen? And this is not an isolated case, of course, what happened to Ilse. But in terms of awareness, in terms of preparedness, in terms of preparation by physician health systems in general, healthcare facilities in general, what is your experience? In terms of sepsis management and sepsis awareness, and what can be improved, and actually what are the challenges? Why there are still cases where two doctors say, yes, I would have acted the same way and not differently?
First of all, thank you very much to have invited me. Yes, I mean, that what I have observed that over the last decades, as a clinician, we have received many important clinical tools that help us in early diagnosis, in better treatment of sepsis. And the scientific societies internationally and nationally have worked a lot on that aspects. What I fear is that probably only specialist society have worked on that. I mean, I'm representing a society, the European Society of Anesthesiology and Intensive Care, physicians that are involved every day in treatment with critical ill patients in a multidisciplinary approach, because I mean many other specialties contribute. But we are the intensivists. We are the I would say the last ring of a long chain, and the main guidelines have been focused on the critical ill patients. Probably too late, because the majority of sepsis happens outside the hospital. I mean, the 20% of the sepsis is in hospital. The rest is outside the hospital. And inside the hospital, we are also in the hospital, we are a small part. So we have focused probably on the worst cases and not attentioned correctly what happens before. And I think this is the moment we have to move the next step. For sure, we need to follow the evolution of, I mean, I would has already been mentioned, the One Health approach. I mean, it's important now to put sepsis in this context and to follow the evolution, because I think that sepsis is a clear example. I mean, how difficult it is to follow with appropriate guidelines the evolution of phenomena, and sepsis is also, I would call it a cross-cutting healthcare problem that correlate with other aspects, other issues we have, like antimicrobial resistance, infections, and a pandemic, and so a lot of aspects. And so what we need today, I think, is for sure, as societies, internationally, most of all, national society needs to work better on the implementation of we already have in terms of tools, I mean guidelines or recommendations. But we have also to work on considering sepsis as a core part of the infection management system. In that moment, probably we will be able to raise the attention of all the specialists that are involved in treating sepsis, not only the intensivist or other hospital specialties, but also GPs, for instance, because GPs are the first to see septic patients. Maybe we can stress more an earlier diagnosis that is so important. We know how important it is. But also, I mean, Ilse has mentioned the problem after for the survivors, because they really are affected by many complications that for some are unexpected or not known. I mean, we speak about long COVID now, but who speak of long sepsis? I mean, this is a problem that we really need to. So I would respond to you. I mean, we already have tools. These tools needs to be updated and evolved. I mean, I'm really happy that now we will receive also some guidelines from the World Health Organization in the coming months. But also we have to work on implementation and to expand the awareness among other specialties and stakeholders, for sure.
Excellent, Eduardo. Thanks for touching upon such a variety of points. I'm sure they will trigger some discussions, because I think it's very, very important as elements where that the European Sepsis Alliance insists a lot in terms of multidisciplinary approach, like interconnection with other issues, such as AMR, pandemic preparedness, etc. And then also Ron has some experience to share in terms of inclusion of sepsis within infection management in health systems. So I would like to make a connection between what's happening in Belgium to what's happening in Switzerland. In a way, they are similar country in terms of size, both federal countries, also in terms of political and perhaps health systems as well. And would like to hear from Nora, actually. In Belgium was clearly, there was some political initiatives that didn't reach exactly the level of attention or triggered the initiative like from the government, but then the patients came, the voice of the patient and survivor came, and that really moved the government to take action and start the process of a national plan. There was not the same, let's say, trigger in Switzerland, right? So what happened there? So what can also start such a process?
Yes. So I think in Switzerland what was really important was that for the Swiss National Action Plan, there was a huge workshop held, and so leadership by Lorraine Schlappach, and a pediatrician intensivist, and some colleagues. They gathered a multidisciplinary panel. So we had clinicians, academics, but also representatives from the policy and patients and families. And we had a large support also from colleagues from other countries who supported us, who had already led successful or implemented successful action plans and programs. And I think this was really crucial that they helped us to organize the workshop, but then also helped us to raise awareness and to put it on to put it on the agenda. So, and during the workshop, the panel formulated like 4 overarching recommendations, and then the Swiss National Action Plan was published and in September 2022. And during the workshop, we also had representatives from the newly formed Federal Quality Commission. And this Quality Commission is an extra parliamentary organization, committee, and they advise the Federal Council on development of quality improvement programs, but they also have the possibility to grant money to projects for quality development, and they also have a scheme how to fund national programs. And after the workshop and the formulation of the recommendations from the panel, we were starting to preparing an implementation plan, and in July 2023, the Federal Quality Commission granted 10 million Swiss francs for a 5-year quality improvement program to implement part of the recommendations. And this quality improvement program is jointly led by 3 healthcare organizations and physicians from the University Hospital, Children's Hospital in Zurich, the University Hospital in Bern, and the University Hospital in Juve. And so it comprises 4 pillars or 4 work packages. And the first work package is all about raising awareness and promoting sepsis advocacy in the public, but also in healthcare workers. So it also comprises a national sepsis awareness campaign. And the second work package, which is also led by the University Hospital in Bern, is an educational program and training program for healthcare workers, but we also want to include it in the medical training or in the curriculum. So we are focusing on terminology, but also that general knowledge in terms of early recognition, treatment, but also post-sepsis sequelae and care. And one of the main pieces, of course, is the implementation and development of clinical standards for early recognition, treatment, but also follow-up care for sepsis survivors and their families, which is led by the University Hospital in Juve, and they actually have already implemented a very advanced and local program. So they will leverage this program they have developed there, but then also we will adapt programs and pathways from other countries to meet the Swiss requirement. And then at the University Children's Hospital in Zurich, we are leading a work package which is all about evaluation of the program and also benchmarking, and we will build up a national sepsis registry to allow surveillance, but also trends and hopefully good data quality. Yeah, so that's...
Excellent. Yes, fantastic. No, I think you really spelled out some key elements which are common from what we see to other plans, which makes totally sense. Now, Ron, I think you are in the best position, knowing your experience, knowing you, to connect some of these points that were raised. We know your long experience in the UK, so perhaps now we can see the perspective from the country. You've been at the 4 updates of the plan, right, if I'm not mistaken. And then also in terms of patient support, it was mentioned by Eduardo and Nora as well. I know your organization actually does provide that service. Now, is it something that should actually integrate it in the health system? Is it integrated or not? So talk us a bit more about what's going on in the UK right now.
Thanks so much, Simone. So it's almost 10 years ago now that my organisation, the UK Sepsis Trust, met with our then Health Minister, Jeremy Hunt, who's now our Chancellor. And he became extremely persuaded to act on sepsis following the death of a young child from sepsis. And the child's mother came with us to meet with Jeremy Hunt. And so we enacted a national sepsis strategy. And it did include public awareness. And public awareness in the UK is now really quite high. We have sepsis advertising really on every single NHS ambulance across the UK, which represents 95% of the ambulances in our country. We've had storylines in 7 different soap operas around sepsis. We have multiple presentations in national media, in online print, as well as television and radio. So we are raising public awareness. The second thing that that the health minister wanted to do was to improve the way health professionals reliably recognise and respond to sepsis within the healthcare system. And we went from a baseline position, which was even then better than some countries, of 32% of patients receiving antibiotics within 1 hour, to a position where we had 85% of patients receiving antibiotics within 1 hour. And we were able to demonstrate that mortality within England reduced from around 30% to around 20% just by improving basic access to healthcare. And the third thing he wanted to do was to strengthen GP approaches to sepsis. So he brought together all of the electronic informatics companies and said, we're going to automate sepsis recognition prompts within these systems. So we had a 3-pronged approach to improving outcomes from sepsis. But of course, then COVID-19 arrived. And as has happened in many countries across Europe, the resilience of healthcare systems has been significantly challenged, and many healthcare systems, including the NHS, have not yet returned to their pre-pandemic levels of resilience. So we have a new problem. We have to now move forward and think, what next? And yes, absolutely. I'm meeting with the NHS executive next week. We will be calling for now a registry, much better data, much better intelligence. Also, you've had cancer, and if one develops breast cancer, you would expect that the markers of the cancer would be measured, your genetic markers would be measured, and the therapy, the treatment would be tailored to your cancer. In sepsis, we have a single definition that we apply to everybody in this room, as well as to somebody who's very frail and elderly, and we have effectively one treatment to offer. We need to build data so we can move more toward precision medicine. Now, you touched on survivors. I would say it's not just about survivors who need support. In most European countries, if you have cancer, you will expect psychological support, rehabilitation package. With sepsis, nothing like this. So our charity in the UK employs support nurses who help people, employs psychologists, employs even nutritionists and dietitians to help to advise people. But it's not just survivors. It's the families of survivors who need our help, as well as those bereaved. So what we're calling upon our government to do, it's naive to think that we, in the UK or a country with a population of maybe 70 million, we would expect nearly 200,000 people to survive sepsis every year, and the government can't afford for everybody to have a rehabilitation programme. But what we can do is to bring online self-directed rehabilitation into the hands of those families, into the hands of those survivors, to engage themselves in their own rehabilitation journey with contact points for healthcare should they find themselves not supported or deteriorating. So those strategies are what we're going to be putting to the government next. But just to finish, this is not just about health professional education and public awareness. This is about the whole of society. The fiscal burden, the cost to society of sepsis is approximately 5 to 6 times higher than the direct cost to the healthcare system. And it's really important that that's brought to government's attention. We can't afford not to do this.
Exactly. Thanks, Ron. You really also brought some additional elements on the table, like also personalized medicine that everyone talking about, people-centric health system. We hear about this all the time, and I think this is really what it is about. I wanted to close a bit with this first round with putting all the elements on the table. Like also, I would like to hear from Ilse again, as you and your friends from Sepsibel are very much involved in the structuring of in the process of the national plan. Actually, did you see some? There are some parallel with what the pillars of the plan in Switzerland, or what Ron has just mentioned. I think there are some key elements in terms of awareness, education, of course, guidelines or standards, etc. Is it mirror?
We had 2 work groups with several doctors, nurses, and also sepsis survivors around this national plan. And it has 7 sub-work groups have been defined. And it is a bit similar to the situation in Swiss. There's a work group around awareness. One is antimicrobial stewardship, early recognition, early treatment, advanced care planning, and then post-sepsis care and registration and surveillance and research. So the national plan should cover all those areas that we see that a lot of gaps in Belgium. We have gaps. There is a lack of awareness. The word sepsis is never mentioned. I met several sepsis survivors who read their own medical file, and it's only then that they discovered that they had sepsis. So people go home and they don't know that they had sepsis, and they don't know anything about the sequelae, and they have a long search regarding, for example, pain. They have pain in their fingers or face, etc. And they have a long search to know what is happening to me. And I met a teacher, she's 36 years old, and her search, she don't have any amputations, but she has pain in her fingers. And the search for her dured 1 year. And they said to her during that 1 year, you imagine that pain, it's a post-stress syndrome. And the neurologist, after 1 year, said, I see on the brain scan that you have irreparable brain damage. So it was a horrendous search for her. When we look to the situation in Belgium, you have to have luck in what hospital you're in if they recognize early sepsis early enough. Protocols for early treatment, there doesn't exist in a lot of hospitals. Post-sepsis care, I already said it. I always say I have luck that I lost limbs because I had an excellent rehabilitation. But when you only have neurological problems, or you have a fatigue, people don't know and people don't recognize, and there's not a lot of acceptation of that problem. And then the last one, registration in Belgium. There is no registration. Sepsis isn't registered. So we don't know how many sepsis deaths there are. We have the study, luckily we have the study of RUT, the global economic burden on sepsis, where we know that there are a lot of sepsis deaths and also survivors with a lot of sequelae.
Yeah, thanks, Ilse. Also, I think it came out from in the last few minutes the issue of surveillance, the issue of data collection that definitely contributes to knowing to know more about sepsis. How do we overcome? What are the challenges to that? We know, of course, there's an issue with the correct use of ICD coding, etc. What about even if there was a correct use of ICD coding, how do we manage to have the same knowledge of the issue like we have for other diseases like cancer, antimicrobial resistance, for example? There's some frustration also within the European Sepsis Alliance about the, frustration. In the sense that, of course, without due attention to AMR, the frustration comes from a mismatch between the burden of AMR and the burden of sepsis, and the attention that is given to AMR and the one that is given to sepsis, which is actually a consequence of AMR in a way. So the two things you said are very much connected. How do we overcome the challenge? How do we make sure that the health system collect data? Is it an issue at healthcare facility? Is this a more structural issue? How do we make sure that we involve institutions like the European Center for Disease Control, the CDC? What, in your perspective, and perhaps I'm asking the three of you, some thoughts of that. How do we make sure there's more awareness and more knowledge from about?
So if I could start, Simone, simply because I have the microphone. In terms of what do we mean by these data? If I go to my government and say we need a registry around sepsis, they say we already have this, or they don't. They have data on pathogens, they have data on antimicrobial resistance among pathogens, and it's not good enough. Coded data is administrative data. It's not intended to answer clinical questions. And until we understand what we mean by registries, what we mean by the data we need, we will get nowhere. So what do I mean by it? And my colleagues might have different perspective. We need the demographic data. We need the physiological data, the vital signs data. We need the laboratory data, not just from the microbiology laboratory, but the hematology, the biochemistry. We need to build all of these data together. We need to understand what recovery looks like. We need to identify the blueprint for someone who's deteriorating in the community. So we need data to be interoperable in order that we can truly understand. We can wait for 3 or 4 hours and build more information. Then we can move forward to save more lives from sepsis, but also deliver excellence in antimicrobial stewardship.
I agree with you, but what we lack is a structured way of data collection. And if we have not a structured way of data collection, we cannot even ask to have sepsis as an indicator of the capacity of the healthcare systems to prevent, diagnose, and treat infections in a broader sense. So that's why I very much appreciated the initiative that the European Sepsis Alliance launched a few months ago, when we ended up in an open letter that we have published and was signed by the European Sepsis Alliance, the European Society of Anesthesiology and Intensive Care, the European Society of Intensive Care, then the Microbiology and Infectivology, and Neonatal and Pediatric Intensive Care. I mean, at the end, what we have asked is to structure in Europe a data collection systems, and probably the best way is to rely upon existing organizations like the ECDC that has behaved so well during the pandemic, but that has not in its mandate the scope of data collection on sepsis. So why not to structure something like that in Europe, and then because in some countries already exists some registry, but not so well done. I mean, all the data have been shown are, sorry if I used to say not true, they are extrapolated data. They relied upon studies that have been published more than 10 years ago in some countries, not in all countries. So really, we lack of a true picture. And the true picture really can raise much more awareness in politicians, in institutions, and this is very, very important. I mean, as a physician, I mean, I rely upon data, and so as a researcher, I need data, and we have not, I mean, a structured way of collecting them.
Yes. Nora, you mentioned that. Yeah. Okay, I was going to open the floor to the, but let's do that right now. So let's collect some questions from the floor.
Thank you very much. Probably this is the most important thing of say there is a need of registering data. I am struggling in my country to collect data 20 years now. And every time ...3 hours daily to give good quality data. So, because I've seen that, and I know that there is only one way to escape this. you need a structure, as you said, to collect data, but you need to find a way to fund people who work in each and every hospital for this. And I suggest that all of us, we ask directly from the existing programs like Horizon that they open a call where all of us, we go together and we ask precisely for this.
Let a couple of questions, I would say, and try to answer.
Hello, my name is Birgit van Hursten. I'm a pediatrician. I trained in France, in Germany, and in the UK, and I'm now practicing here in Belgium. So I know very well what Ron describes because I was working in the UK from 1997 to 2008. It was the period when meningitis was high on the agenda, and that's one of the success stories, and I think you can build on that because sepsis awareness was drummed into everyone during the time when meningitis vaccines weren't available and meningitis was a major health issue in the UK. I was really shell-shocked when I came because I had seen 1 or 2 cases of meningitis in the sort of 5 years that I was a doctor, and then when I arrived in the UK, within a month or 2, I'd seen 3 others. So it was impressive. But what I'm doing now, so I moved on from hospital medicine to working in the sort of community environment. I'm consulting anything from healthy babies, concerned parents, and I see a lot of these subtleties now that I never encountered in the hospital, and I think that's the point that I want to make. Finding the joint between the care in the community and the care in the hospital. Sepsis, as we hear, it comes along, the symptoms are very subtle. Ilse beautifully described it. It's symptoms that would be expected in the context of a surgical procedure, that you have pain. It would be expected. Maybe you feel a bit faint. Okay, that can happen. But it's putting all this together, put the pieces of the puzzle together, and it's pervasive. So you get surgeons who encounter sepsis. You get obstetricians that encounter sepsis. You get internal medicine doctors, and the anaesthetists, they know it all. They are in the intensive care. They would spot it immediately, but I think that's training. So that is why I think sepsis is so complicated, because it's a silent, it starts with very symptoms that are very subtle, and each symptom in itself is not a red flag.
Any other comments? Yes, perhaps to Antonio and the gentleman.
Okay, thank you. I'm from Catalonia. Catalonia is a region of Spain. You know very well this. And some years ago, we were able to convince the health department of our government to implement a sepsis code. And this sepsis code was including a registered system funded and supported by the health department. And I think this is crucial, as Evangelos comment. If you don't have good people that are collecting properly the data, I mean, the survey or the epidemiology data are not accurate. So after this, the last 10 years, I have a question for the panel, and I think this is a key point, is the feedback. I think the feedback to any hospital is a key point to try to detect the areas or the the sepsis process that where should be improved. And also this should be anonymous in order to be possible to be compared with the other hospitals and related to the money that they receive from the government of the hospitals. So this is economic input, and second, the possibility to improve your care along the time.
Was there a question in there, Antonio?
Well, the question is for Switzerland or for UK, what is the feedback system? Because I think this is very important.
Do we want to react to these first three comments,
Yeah, I think so.
and then there are another couple of questions behind?
It's not on.
Expecting from us or from such a registry in terms of like quality improvement and quality measures. So I think you can incentivize that as well, that if you collect high quality data and data on process and balancing measures, so we are not at that stage yet, but we are planning it to integrate it in the data collection as well. So not only, I say only, but it's not only about outcome measures and evaluation and epidemiological data, but also about process, balancing measures, and quality data. So I think this is really important to feedback. And I was also, when I was listening to Ilse last time, I also thought like it's really interesting and relevant that we include patients and families as well in the evaluation. You know, that they can provide feedback. Are we really like heading in the right direction, and are we really measuring what is important to them as well? So I think we have to measure data on different levels.
Thank you. Just picking up on Antonio's point, just 2 points to make. The first is about the finance. For me, this is about commissioning for excellence. This is not about a coded entry for sepsis. Here's your 4,000 euros for treating that patient. We don't accept that. Again, sorry for the analogy with cancer. We don't accept that for cancer. In cancer in most European countries, there are targets for waiting times before you see a specialist, targets for definitive intervention. You have a move toward precision-based medicine. We're never going to get there with sepsis until we grow up and commission for excellence in infections management. Again, in some European countries, a clinician like me can't innovate. We can't bring a novel diagnostic near to the patient. We can't bring novel biomarkers nearer to the patient because the budget for that lies with the laboratory, and there's no incentive for them to bring these devices near the patient. That's just one example. Until we commission, we can't do that. The second point I want to make, and it hasn't been raised so far, is in our countries, who is disproportionately affected by sepsis? It's people from areas of higher socioeconomic deprivation, and it's people of non-domestic ancestry. Most of us in this room are of Caucasian descent. Most of us have jobs and incomes, and we are less likely to be affected by sepsis. We really need to focus on those sectors of society within our own countries who are at greatest risk.
Thanks, Ron. I've seen, yes, thanks, Ulrika.
Hello, I'm Thierry de Sot. I am lecturer in natural language processing as part of AI at the University of Applied Sciences of Rotterdam. So I heard the need of having registered international data. And of course, as I know that the medical world gradually is opening up towards integrating AI. So my question, especially I think in the early detection of illnesses, there is a growing awareness that AI can find patterns which humans in an entire life will never find. So my question is, what is the attitude and the opinion of ESA towards integrating machine learning techniques and AI, maybe as a next step if you succeed in a data registry?
Yeah, so there was also, you had your hand raised before? Maybe, maybe we can collect both, and then yeah. So we give time to reflect on that as well.
Thank you. Yes, I'd like to emphasize that we can learn a lot from long COVID patients as well. The similarities, they have a lot in common. The post-sepsis patients, it was already mentioned by you, long sepsis, and I think there's so much knowledge also to be shared. And there are still a lot of silos and borders, and we should join forces more. And there are also a lot of, I'm from Sepsis and Daarna, sepsis, a survivor from the Netherlands. And we have a lot of sepsis patients who were treated in the general ward. They weren't admitted to the ICU. And they are facing a lot of sepsis sequelae as well, and we don't have a picture of the numbers. But we do have a picture of the societal costs of sepsis in the Netherlands, since the article was published about that in January this year. So we hope our government will be reading that article also.
A couple of interesting points. One about integration of technology, actually, that we haven't touched really upon, and in sepsis early detection and treatment, and one indeed again about post-sepsis syndrome, as is known. So any view on technology or experience for that matter? It is true, I admit, it's not a topic that we as an organization have yet delved into, as we are still very much focused on awareness, but it is absolutely something that's very pressing, as it can definitely help us.
Yes, I think that is very interesting, your question, and yeah, I think that we have to rely upon new technologies and the potentiality of the new technology to increase our capacity to recognize sepsis. Coming back to data collection, I think at this moment, in my perception, we are working, as you said, in silos, because yeah, I mean, we collect data in hospitals, but what about all the other world outside the hospital, and also inside the hospitals? Probably there are wards that are much more prone to recruit data and so on. But then we have just a small part of the picture. It's just a piece of the puzzle. So we really need to structure the way we could collect data in a more broader way, including, I mean, possibilities with the new potentiality of technology. How to do it, I do not know, but I think that we need to focus on those aspects and broaden our capacity of data collection.
Just building on Eduardo's point, I think there is a real use case opportunity here. It's such a big topic that we can't discuss it in the remaining few minutes, but there's a real use case here. People who've had sepsis are frequent flyers. They're at increased risk of readmission to hospital with infection or sepsis for several years to come. I think there's real opportunity with pattern recognition in user input data. We could use tonal analysis for, as you say, natural language to understand what the red flags for deterioration look like. Who's to say that interplay with smart devices can't add value? Who's to say that changes in step count or changes in stride length are inferior to blood pressure changes, heart rate changes, respiratory rate changes in identifying people who are deteriorating? So I think there's a real use case that should be implemented quite rapidly in following up people who've survived. Sorry, Nora.
Nora, is something that you're also looking in as thinking you integrate, or?
Yeah, yes, because the University Hospital in Lausanne, they've already integrated the early warning score into the medical record, electronic medical record. Right. And it creates an alert. And so they have been very successful in this, but of course it relies on the system itself, so it's not transferable to other hospitals and other systems. And another thing we are now trying to leverage is that we had an initiative, at the moment there's an initiative running in Switzerland, and it's the Personalized Health Network, and they are creating national data streams, so coming from the clinical data warehouses from university hospitals, and they create like these uniformed data streams. And one of the data streams is also collecting ICU data, and they have a sepsis stream. So what we are trying to do is that we could like create a sustainable data stream with an ontology and that crosstalks. But of course, this is only possible in university hospitals at the moment, and we are missing a lot of patients. And I think what Ron alluded to is really important, that we pay attention to equity and not like repeating problems with data collection we did in the past. So we should have high quality data also on non-university hospital and patients not treated in trials.
I would like to say two things. First of all, in the hospital where I was in, they used an early warning score. But I talk about it with nurses who are working there, and they said when the system gives an alarm, we didn't have to do anything about it. Just they don't have to bother it. I had news 5 or 6 and 7, and they didn't have to do anything. So there definitely needs also education. And the second thing, I'm a survivor of cancer and also of sepsis. The difference as a survivor of both is so huge. I was contacted by breast nurses. I was given a pink book full of cancer survivor testimonials. And I still receive a very interesting and beautiful magazine on how to move on as a cancer survivor. But when I was home, I had so many questions about sepsis, and nobody could help me. I even went to a cancer organization, and you know what they told me? They told me that sepsis is not a problem in the Western world. And then you feel alone. You feel very much alone. So we need more. We don't even have a brochure in Belgium about how do you have to live your life after sepsis. So that were the two things I wanted to add.
Thanks, Ilse. I think it's very good as we're heading to the closing of the debate, yes. I wanted to finish up. I wanted to close up by really highlighting. I mean, there are lots of, looking at the registration, there are the vast majority are physicians. I was checking at the live stream, and we have really attendance from everywhere, also from Africa, Asia, and many European countries. So there are many potential leaders out there who are listening to us. They are listening to what you guys are doing, your best practices, they listen to your experience. And what I would like to really close with literally one word each, and see, okay, what can they do? What can they do to initiate progress? We heard only less than 10% of UN countries have implemented a prioritized sepsis national system. Maybe there are other potential. The 90% maybe is listening to us. What can leaders do to implement? Really one word, one key word, and then we'll close the...
4 words, make sepsis a priority.
Collaborate.
Collaboration.
sepsis as an indicator of quality?
Indicator of quality of assistance.
Advocacy.
Advocacy. Very good. And in fact, these are the key words that came from a discussion. I think you can all confirm. I think it really takes leadership. It's a multidisciplinary approach that is needed. It's very key access to funds. That's important for data collection, but simply for the implementation of the plan. Integration with other policies, with like antimicrobial stewardship, for example. The involvement of patients and families as well, and awareness and advocacy, as Nora did. So I think these are the elements where we should all focus, and we hope that also people listening to us, maybe they feel motivated, and they will, maybe something will start from today, something new. So I want to thank you very much with a warm applause, the panelists for today, and we look forward to the continuation of the program. Thank you.
Thank you so much. Really interesting panel debate here. I'd just like to say that we have 240 people right now attending online, so that's really nice. So we're not that many here, but we are a lot around Europe and the world, as Simone said. Before lunch, we'll have one more talk, and I'd like to present Konrad Reinhart, who is president of this Sepsis Stiftung, but also, of course, the founder of Global Sepsis Alliance. And you will talk about synergizing strategies on AMR and sepsis. Please welcome.
Thank you. And let me first say a word. I was very disappointed by the contribution of the head of Santé listening 6 years after we have met here for the first time. I don't have seen any change in respect to the simple focus. It's just on AMR, and we need to overcome if we really want to make a difference. These have been the figures that we have presented when we launched it under the European Sepsis Alliance under the patronage of Dr. Commissioner Andriukaitis. And these figures that you see here are extrapolated from the very first studies from our good friends and the group of Adam Linder, based on an incidence around 700 per 100,000 in Sweden and a mortality rate of only 15%. And if you extrapolate to this, you come up with the 3.4 million annual cases in Europe and 680,000 annual deaths. Probably this number of deaths is twice as high because, for example, mortality in Germany is 30% and not 15%. I'm pretty sure that this applies for the majority of the European countries. And rightly, Dr. Tedros called it a tragedy that most of these patients and deaths are preventable. And as I said, it's unacceptable that 6 years after the launch of ASHAS has changed in this respect. And if you look at these numbers conservatively, at least 200 million preventable deaths, if we assume that only half of them is preventable. And I'm not counting the number of patients where the sequelae, the long-term sequelae, could have been prevented. So these are the figures, and it's unacceptable that within Europe there are countries who have basically the same resources which differ by 100% in terms of mortality and what also means long-term sequelae. Can you move it forward, please? It does not. It does not move. So, and if you look, I got really angry when I have several months seen for the first time this AMR fact sheet by the EU Commission. They say, rightly, Professor, there are 35,000 deaths from AMR in Europe. I know from our German colleagues who are advocating on AMR, it's 2,000 in Germany. And if you look at these numbers and have heard what is spent, that every Ministry of Health around the globe and also in Europe has not only one person who advocates within the ministry on AMR. And I'm not saying that this is wrong, but we must not forget there may be a problem, Marvin. So go back, please, one. If you, what I wanted to show with this slide, which one back, please. One slide back, please. One forward. No, one forward, please. So this is the data where again our colleagues from Sweden have updated their data. Now they come up with an incidence, hospital incidence of 6.7% of sepsis cases. This was during the COVID period. And when they got rid of the COVID patients, in this case, this was 4.5% of all hospital admissions in Sweden was by sepsis, which makes a population incidence of 850 per 100,000 population. At the same time, they looked on the incidence of bacterial sepsis by antimicrobial resistance. It makes up 17 per 100,000 population, which means 2.3% of cases of sepsis in Sweden are attributable and associated with sepsis. And interestingly, the mortality rate there is higher. It's 24.5%. Overall, it's 15%. But just to make you aware that when, of course, AMR is around, but I have hardly seen on my ICU, and I perhaps am the one who has seen more sepsis patients in his life on an ICU. I had often a hard time to find anybody when I was addressed by press. Show me somebody who really, where the biggest problem was AMR. Next slide, please, Marvin. And this is data from the CDC, where you see, and it's on the website of the Staunton Foundation, where you see how disproportionately the awareness for certain conditions are. And ironically, it's also in the US, it's 35,000, as is it in Europe. Next slide, perhaps. So, and COVID adds, of course, to the burden of sepsis. This was set out already in the accompanying report of the WHO sepsis resolution. That also influenza, of course, and this is also not in the data when it comes to sepsis. And of course, also corona, SARS viruses, etc., may result. Next slide, please. In sepsis, and we met and even this is electronic health record data from Massachusetts, who have looked up in Massachusetts, in these hospitals here, the incidence of non-COVID sepsis, which is 4 times higher than the incidence of COVID sepsis during these times. Everybody knows now about COVID. And we have really an issue, next slide, which is awareness. And as I mentioned initially, Tedros was right. The majority of sepsis cases are preventable. And this was demonstrated already in the 1900s, where the crude mortality rate was 800, only interrupted and increased by the Spanish flu, decreased to around 50 per 100,000 deaths from sepsis. So it's preventable, and it's also preventable in high-income countries, where in Australia it decreased from 35% to below 20% just by introducing, not speaking about sepsis, but just by introducing rapid response system, which means educating the nursing systematically on the early sign of any deteriorating patients, having rapid response teams and not reanimation teams, which still most countries have. And they went on, next slide please, and they introduced these rapid response teams. We still in most countries come active when we have reanimation. Next slide please, where you see that also there, and this is data recently published from the state of Victoria, they launched a quality improvement campaign for their hospitals. Think sepsis, act fast. And they were able to increase the number of patients who got this sepsis pathway, which means early recognition and acting, and increasing it to 78%, and mortality decreased from 17% we would dream of if you had it in Europe to 11.3%. And this reduced in a reduction of hospital uses for more than 4,000, almost 4,000. The treatments cost went down by 11.7 million, and the money that was used for this campaign was 1.7 million, a return of investment of 600%. Next slide, please. The US was able to demonstrate by introducing mandated actions for all hospitals in the state of New York. And mortality rate within 5 years went down from 30 to 20%. And what you see also here, that sepsis is a time-critical disease, and any delay in administration of antimicrobials is significantly associated with more mortality. And again, we are asked when we speak about sepsis by GPs, by anybody, what about AMR? So people are scared and withhold antimicrobials in patients who really badly need it. Next slide, please. This is the situation in Germany. We tried with 40 hospitals and assessed that at this time only 1/3 received the antimicrobials in these hospitals within the first hour. And what we found that any delay, and this is more than 4,000 patients now, in therapy increases mortality rate by 0.5%, and also this is true for surgical source control. Next slide, please. And this is this was a bottom-up approach by intensivists. They complained that the other disciplines did not get involved. Emergency department, internal medicine, surgery, etc. The hospital administration and boards wasn't support, lack of time, etc. Next slide, please. So that's the situation. And just to reiterate, it's not only in the hospital. This is data from UK. In patients with bloodstream infections / sepsis due to urinary tract infections. And any delay also there resulted of giving antimicrobials resulted in an increase of mortality. So that's why, next slide please, that's why we made a difference. This is data from, because we discussed, we need data from Sweden. They could demonstrate, they have data what happens in the outpatient setting, they could demonstrate that a delay of 24 hours, between 12 and 24 hours, goes along before a patient comes to the hospitals, before he has addressed a GP in the community, increase the risk of dying by 4 times. So this longs, and next slide please, longs for education of lay people, that they understand this is not the case still. This is an official poll in Germany. Most of them don't know that influenza and COVID may also end up at sepsis. 65% think still that only wound infection result in sepsis. Next slide, please. And you see this data. We have made some progress over time, but we have still a lot of work to do. And this poor knowledge is also resulting in poor vaccination rates. Next slide, please. And it's possible, and we can skip this due to the great work that we have. Next slide, please. And it happened, it was possible to decrease mortality in Ireland. Next slide, please. And unfortunately, it's still true what Osler has said around 1900, that humanity has 3 main enemies, and by far the greatest is fever, which stands for sepsis. Next slide, please. And if you look at this data, and Mariam has already alluded to, still nowadays, there are more deaths from sepsis, HIV, hunger, and war, and also from cancer, but we have this poor awareness. Next slide, please. And finally, we have talked on long-term sequelae. They are completely the same. They differ just in the degree, depending whether you have long-term sequelae from COVID-19, influenza, or sepsis. So this is published now. But in Germany, for example, there are now COVID ambulances. But I was unable over 3 years to get across the message to our ministry that this is not acceptable by sepsis survivors, which are 5 times as many as COVID survivors. And we need to work together. It's the same problem. Next slide, please. And we applauded our Minister of Health that he brought into the G7 presidency of Germany this statement. We need to synergize this action between AMR and sepsis. And they also said, also G7 would applaud and foster the implementation of the WHO sepsis resolution next. But it did not happen. And we have to learn, and this is my last slide, what Rudolf Virchow, a famous physician at his times, has always said, that medicine is policy at its large, and that the medicine has the obligation to tell the policymakers what has to happen, and they have to support it. And rightly and best understood, this message was by our colleagues from cancer, who in the 50s and 70s asked for a moonshot for cancer, for a Manhattan Project, and this is definitely what we need, given. And with this at the end, and thank you for your kind attention.
Thank you. Thank you, Konrad. So we're going to break for lunch. All of you who are joining us online, be back here no later than 2 o'clock, because then we have started the program again. Marwin, are we offline now? Can she see us?
No.
No, okay.
Okay, 3, 2.
Okay, thank you, and welcome back after lunch. I hope you all have had some more food into yourselves. You have full of energy because we have 2 more panels to do. And I would like to welcome up on stage, I'm going to moderate this panel myself, but I'd like to welcome Ron again, and Anne and Ulrika, there you are. And then we also have Shashad joining us. I'll do more of a presentation, but please do come up on stage. Choose a chair. Okay, so here in Brussels we have Ron. You already had an introduction of you before. If we have newcomers in the audience online, Ron is CEO of and the founder of UK Sepsis Trust, and also a member of the ESA steering committee and vice president of Global Sepsis Alliance. And then we have Anne, who is director of prevention and early detection of cancer at the NGO called Stand Up to Cancer here in Belgium. And you also have a background as a PhD in pharmaceutical science and been researching for that in a quarter of a decade here in Belgium. And then we have Ulrika Knutsson, who is chairman of the ESA Patient and Family Working Group. You were also one of the co-founders of that working group within the ESA, and you've been also sitting in the steering committee of ESA. And you normally work at a Finnish food company called Paulig, but you have also obviously a personal stake in this matter, since you have a husband who has severely suffered from sepsis. And then online, last but not least, we have we have Shashad Kiavash, who is joining us from Stockholm in Sweden. Shashad is a sepsis survivor who had a sepsis in 2012 and suffered severely. You had both your legs amputated, but you turned that horrible experience around to something very, well, we have to say, extraordinary. You decided to, as a part of coming back to life, you started training triathlon, and you became really good at it. And you went to Rio in Paralympics and competed for Sweden. Thank you, from Sweden. And of course, you're also part of the board of Sepsisfonden, the Swedish Sepsis Trust. That is my little baby. A warm welcome to you too. I don't think you can see us, but we see you. Can you see us? No.
I cannot see you,
but we see you very clearly.
You can see me. So,
yeah.
Okay.
That's good. Okay. Before we start the discussion, I would just like to invite you all to give a little take on the topic that is the topic for this panel, which is understanding sepsis from silos to common fights. Let me start with you, Ron. You're sitting closest.
So. Two immediate thoughts on this. Firstly, the policy level thought, which is that we need to start considering infections management as a whole. This is around the rapid treatment of sepsis, it's around antimicrobial resistance, it's around infection prevention, and of course, pandemic preparedness. Every one of those is a mission to reduce avoidable harm from infection. And at a policy level, we need to sit up and take note of that. The second point I'd like to make very briefly is that if we're trying to effect change within an individual country, we need to understand that the silos are not restricted to health professionals versus the public. The silos are across the whole of society, and we need to understand how we can collaborate with media, with industry, with retail, with every sector of society to get a common message around sepsis and antimicrobial resistance.
Okay, Anne.
Okay, so my purpose why I'm here today is that I want to learn from you, the sepsis survivors, and sometimes also the cancer survivors, what we can do as a non-governmental organization, how we can do some advocacy, definitely, we also can help to create more awareness with different people, patients suffering, for example, from cardiovascular diseases, from diabetes, from cancer, because they're more at risk than the healthy population, to say it. But also the informal health givers and the family, and also the healthcare providers, of course, because that's what we learned, that there is also not enough awareness at the healthcare providers, and how we as an organization can help you to achieve your goal. Is getting rid of the sepsis. The ultimate goal is getting rid of the sepsis. Okay.
Ulrika.
Well, I had a long ask on behalf of my working group. But I have a dream to share, so I don't know if you would like me to quickly share it now or later. So I journaled a little bit this morning, and in the view of time, I'll just quickly share with you, put it in writing. So I had a dream last night about a healthcare system without silos. And sepsis is still there, don't worry, you know, but it became much more the most preventable and cause of death and disability. So sepsis is known in this society without silos by its name. It's called, clearly. Everyone, healthcare practitioners, citizens, are aware of it. They always rule it in. It's mainstreamed, rolled out in the entire healthcare system. Can you imagine, Ron? Early recognition and fast responses work well. Families are empowered and play an active role to recognize the signs. When in doubt, laboratories are always accessible 24 hours every day, and there are even some magic tests to quickly detect it. Hospitals have mandatory procedures in place. Ambulances bring you to the hospital of your choice, and certainly to the right one when urgent care is required. Emergency response is fast, and a response targeted to the patient needs. Families are better informed, know how to spot early signs. They know more about the ICU. They're not scared. They don't run when everything beeps. And they even can help considerably the ICU patient and help ICU function more effectively, which results in better treatment and better recovery for their loved ones. Family also get support during the critical months. They know that recovery can be bumpy and long, and they take care also of themselves and their loved ones. So long-lasting effects, sequelae of sepsis, are known and explained to patients and families. And holistic post-sepsis approach is even offered, being deeply conscious of people who are living with these syndromes and disability. This allows people to come back quicker to normality. And what is normality? Active and happy life. Some sepsis survivors cannot change their disability, but they and their family again are supported, which allow them to adapt better. So, sepsis patients' organizations are also supported by governments, and a lot of activities is organized in local communities, bringing resilience, agility, love, and support to bounce back and return to a happy life. Lots of funds are freed and are available for research for other critical illnesses. So this is the point of my dream. And not only is this the most human, but is also most pragmatic approach that I wanted to share on behalf of my working group. Thank you.
Thank you, Ulrika. That is one hell of a dream, I have to say. One hell of a dream. Okay, Sean. Do you hear us? Yes. Please.
Well, everyone in the panel put it so eloquently, so I don't know if I have anything to add, but I really liked, well, the dream, and I like that. And I also agree with Ron that we need to see it as a whole. It's not healthcare professionals and the patient. I think it's like the media everywhere. We need to, bring it up and speak about it everywhere. So yeah, you guys did a good job. I have nothing to add.
Okay. Let me start by asking you, Anne, whatever. As you talked about before, cancer patients as well as people who have other chronic diseases like diabetes and cardiovascular diseases and so on are a risk group for getting sepsis. I think in Sweden we estimate that around 20% of all sepsis patients are also undergoing some kind of cancer treatment, for instance. In your opinion, how can we sort of bridge that gap in communication so that these risk groups, for instance, cancer patients, are better aware of the potential risk of sepsis? And have your organization worked around this? And if so, how?
Okay, thank you for your question. Indeed, we should work on communication, and it's very important that that people that suffer from cancer, for example, are definitely aware of the risk of sepsis, to develop sepsis. Not only the patients, but also, as I mentioned before, the family and the surrounding of the patient. So that is very important. So we have to communicate with them, although it's not so easy for people that just receive the diagnosis of cancer to give them a lot of information, because they're overwhelmed by diagnosis. They only remember little parts of what is said to them, and they immediately want to start a treatment. And then you have to communicate on, you can have a higher risk to develop sepsis. So that's the difficult part. We have to see when and how can we communicate with these patients, or with the family maybe, or with at least the caregivers or the healthcare providers. So it's not so easy. It's easy to say we have to increase awareness, but to do it in practice, it's not so easy, especially not in the beginning, because they are really, as I mentioned before, overwhelmed by the news of this diagnosis. So that's first of all, but it's not that we don't have to do it, but we have to pay attention and focus, and maybe adapt the communication on a level that also the patients will understand it. And we want to increase awareness without causing panic, because that's what you want to avoid, definitely. Our organization, or my organization, definitely did not enough yet, that I can say, and we definitely want to do better, definitely. What we do is we had also an interview with Ilse, and we put it into our magazine, and it's a magazine which is for free, and it's distributed really to a wide audience of cancer patients and cancer survivors, and actually everybody who wants to receive it can receive it, but it's especially focused on stories for cancer patients. So that was at least one step forward, I would say. Then also the panel reportage, it was sent out in November, I think, or at least few months ago. I think it helped a lot to create awareness. And we also have some information on our website. And our website is mainly it's mainly visited by patients or family of patients that just most of the time, just when they receive the diagnosis, they want to find more information. And then it's mentioned on the website, but of course there is a lot of information on the website. So I think we definitely can do better, and definitely have to think, and that's why I'm happy for the invitation. How can we learn from the patients? When do they want to receive the information? How do they want to receive the information? Who needs to receive the information? And I think that is very important. And apart from that is also as mentioned before, the GPs and also the oncologists are also not fully aware of this, let's say, the complication of the cancer patients. So we definitely have to work, or we can work as an organization on these two sides. And that's what we should do, I think.
Thank you. Ron, you talked and Konrad was talking about it earlier, you have talked a lot about the connection between AMR and sepsis, and that we cannot consider them in isolation from each other, and I totally agree with that. I think maybe within the healthcare system, it's been becoming more a better understanding for that, but on a societal level, and how can we sort of get the politicians to understand this? Can you elaborate a little bit on that?
If I may, firstly, to Anne's point, what we do in the UK is every patient who's being treated with chemotherapy for cancer, it's in the booklet that they're given. So at the time, it's not at the initial diagnosis, it's only once the high-risk therapy's been instituted that they get the information around sepsis. But to the point around sepsis and AMR, I think from my own country, Dame Sally Davies has done more than many human beings, almost any human being, to raise government awareness of antimicrobial resistance. But what's our public heard? Our public have heard that if the government doesn't do something, then in 50 years' time, you might not be able to safely have a new hip. And that's not immediate, it's not personal, it's not context relevant to our children. And that's what needs to change, because all the clinicians in the room know that there are patients in their hospitals today who have resistant infections. I was talking to Adam a moment ago about my home city of Leicester, which is a small city in the UK. If you are from a rich area of Leicester, there is a 40% chance that your E. coli that cause you UTI will be resistant to the first antibiotic. If you're from a poor area in Leicester, it's double. It's 80% resistance. So our public need to hear that AMR is here now, it's immediate, and it might affect someone they love today or tomorrow. The public also need to know that they have a responsibility, that there are actions that they can take. And that includes, of course, healthy living, access to vaccination and infection prevention. It includes responsible approach to seeking antimicrobial treatment rather than using them to cure a viral illness, which of course they won't. And we also need to talk about the One Health approach. And this is about One Health approach in animal husbandry and intensive farming as well. And perhaps there's an opportunity that if we can improve our behaviour regarding the consumption of intensely farmed meat, then we might also be able to positively impact on antimicrobial resistance. So for me, it's bringing it all together and understanding that AMR doesn't actually kill people. Untreatable infection kills people, and sepsis.
Very good point. Very good point. Shashan, you have started in Sweden together with another sepsis survivor, Elin Rantatal, who is also a double amputee. In this podcast, you talk quite a lot about the importance of being seen as a patient, about how healthcare personnel need to sort of acknowledge what the patient is saying and have an open mind, and that you as a patient know your body better than anyone else. In your opinion, how important is that the voice of the patient when it comes to early detection of sepsis?
Thank you. Well, just to briefly give you a background of my sepsis story so you get a little bit of context where I'm coming from. I was an otherwise very fully healthy 28-year-old on a very normal day. I went to work and afterwards I went to the gym. I felt strong and I felt good, but the symptoms began really right after the gym sessions. It was as if a giant worm was squirming around inside my stomach. A few hours later, I called the emergency number for the first time because I had a heart rate of 144 and I was breathing very fast and my body temperature was slightly low. Even though I begged them to take me to the emergency room, and even though I told them multiple times that it feels like I'm dying and that I am very afraid, they told me that I was having a panic attack and that it will get better soon. When I said that I didn't want to be left alone, they responded that they can take me to the psychiatric ward. I said, no, thank you. 4 hours later, only 4 hours later, I collapsed on my way to the kitchen, and my brother, who fortunately was with me at this time, woke up and found me unconscious and my face had turned blue. The ambulance came again. And the paramedics went in with the conception that I am a young female, anxiety and mental health issues, and began to search my apartment for pills or medications that I might have used, because they looked at the whole situation as a suicide attempt. And I remember as I was drifting in and out of consciousness, one of the paramedics was checking my vital parameters, and he yelled to the other one, "It's sepsis. We need to hurry." So they took me to the emergency room, and I was instantly intubated. No one even believed that I would make it through the night. And I spent the following 9 weeks in the ICU, 7 months total in the hospital. I was operated on 53 times, and finally the doctors had no other viable options than to amputate both of my legs below the knees. And even though I try not to dwell on the fact that I was not taken seriously, or that they refused to hear me when I said that I don't have any mental health issues, that is not it. It's inevitable for me not to think that what would have happened if they had taken me to the emergency room, what would have happened if I was under supervision of healthcare professionals when the symptoms increased. Probably my life would have been very different today. So to answer your question, communication is key. It's very easy to put a certain person in a box, right? Young female, mental health issues, panic attack, and making that my diagnosis and feeling content in that realization. So, okay, so we got this figured out. It's a panic attack, right? And not really wanting to hear me out and wanting to look farther than that. And keep in mind that when they came to my apartment the first time, even though I was very stressed, I was still very verbal. I could speak for myself, but I'm not heard. And I think that I came to the realization the more I spoke about my sepsis on TV or in newspapers, that my story is not unique in any way. This has happened to many sepsis patients that I've spoken to. Their symptoms have also been downplayed. They have been told to wait, to go home and rest. So definitely, I think that anyone and everyone can benefit from better communication, listening to the patient and keeping sepsis top of mind, even in those cases that it is not the go-to diagnosis.
Well said, Jashi. Ulrika, you have talked about this too earlier, about that empathetic communication is the key, really. Listening actively, as Jashi is saying, not downplaying symptoms and taking patients and their families seriously. In what way is the ESA and the patient and family working group working with these issues? And do you have any concrete action plans to get this message across? And do you think it's even possible to maybe implement within the guidelines of the national plans these kind of issues?
Well, I think those are very good questions, and unfortunately, we are at a very early stage of raising awareness. So everyone is kind of battling, in this sphere. But of course, we are dreaming of empathetic communication, listening deeply, because family and patients are a ready available resource there. And as I said, it's not only a human thing to do, it's a very pragmatic thing to use it. And we know how stretched are the healthcare system. And, and as has been said, who knows better, your body than yourself or the loved ones who care. And once you listen, there's so many clues and things are starting to clear up, so that's, so we are at the very early stage of awareness. No, we haven't focused, and that's maybe our next milestone, but I think there should be no national action plan, be it a cancer plan or sepsis plan, without family participation, listening, training, retraining, and empathy. And I would distribute brochures to the cancer patients early, in a very human way, because once they fall from the cliff, they are the first to hit themselves very hard, so it's a... I hope I answered your question.
Ron, we have talked earlier about, and you have talked about, I think you've written a white paper about it also, about when it comes to sepsis management, we need to sort of consider them from 4 different pillars. AMR was one of them, but you also talked about pathogen surveillance, infection prevention, and rapid treatment of sepsis. Can you expand a little bit around this? What are the actions needed to sort of get those silos or pillars to work together, so to speak?
Yeah, so the top level policy message is to consider infection management across those 4 pillars. Now, the Infection Management Coalition is supported by healthcare industry, as well as industry regulators and professional societies and advocacy organisations. And at the beginning, when we set out to write the white paper, it was decided by those mostly international organisations to focus on the UK first. So it makes 29 recommendations. I'm not going to go through the 29 recommendations, I promise you. But it's important to note that the recommendations will need to be adjusted for other countries. And the next step is to go to other countries in Europe with similar recommendation. One example of the recommendation is around, there is a pilot that NICE, the National Institute for Health and Care Excellence in the UK, are undertaking around reimbursement of pharmaceutical companies for antibiotic development and antibiotic marketing. It's called a subscription model, and it improves the reimbursement levels based upon the societal value of the antibiotic rather than the individual cost of the doses. And one of the recommendations is to expand that pilot to fuel the antimicrobial pipeline. And the second, equally brief, is to incentivise the integration into healthcare systems of novel and rapid diagnostics to help me, as the prescribing clinician, to make timely decisions around whether the patient needs an antimicrobial, and if they do, which one is going to help them the most. And that will allow us, that innovation will allow us to move forward in terms of both sepsis and AMR.
Perfect. Thank you. Anne, coming from the field of cancer, a field that, as we talked about earlier, traditionally has been better organized around the management around and this within all really healthcare systems, I think, in Europe. Do you think there's something that we can sort of learn from cancer management when it comes to sepsis management? Lessons learned.
Yes, lessons learned. Okay, I think you can learn a lot from the cancer world. Let's say, first of all, the registry, as mentioned often, there is, in my opinion, in each country a cancer registry. So then at least you have a view on the amount of patients. In Belgium, that is lacking for sepsis, I know for sure. Then secondly, we have really some goals that we need to achieve. And the goal is to treat the patients better and also to make sure the cancer is detected as soon as possible. So we have an early detection program as well for some of the cancers, for 3 cancers actually. They put much more money, a lot of money in research on the treatment of cancer, but also in supporting patients when they enter the hospital. There are extra nurses to explain what is happening to the patients. And there is also extra money to collect data, which was also mentioned before, that data collection is an issue if you have to do it on top of all your other work. And there's also efforts in the aftercare for cancer patients. So the mental aspect, I mean, they're really, well, maybe not even enough, but they're really supported also when they leave the hospital. Coming back to the discussion in the morning, they also put a lot of money in the personalized medicine. As you mentioned before, now when the diagnosis is finally set, then it's treated as fast as possible. But maybe some patients are overdosed, to say it like that, or not treated in perfectly. So I think definitely there is room for personalized medicine, and it's a very awkward thing that that companies like Google know more about us than the hospital does. So I think it's not an illusion. I think definitely AI should is the key to personalized medicine, also for sepsis, which is, I think, very, very crucial, because an older man with maybe a renal deficiency or something like that, and that has a sepsis, has to be treated differently than a young woman that comes in. And it also depends, of course, on the kind of sepsis. So there are multi-variables, so it's not easy to treat it in a one-way treatment for all. I think that's also causing the many side effects for the patients, except, of course, that the treatment is often started too late, definitely, but it's also maybe too severe for some patients, and for some patients not severe enough. So it's, yeah, I think they can definitely learn from the cancer field.
And I agree with you. We talked about it earlier, both with the precision medicine, treating every sepsis patient as an individual rather than just having, as you said before, one sort of action plan, you know. So that's a really good point, I think. So let's see if we can make them work better together on national plans and so on to sort of not invent the wheel twice, as we say. Ulrika, you talked earlier about the importance of a holistic approach when it comes to both post-sepsis and long COVID, when it comes to rehabilitation. What do you think is the most important thing for patients in terms of aftercare, you know, the life after sepsis? What is most important for patients today?
I think, as already said, we will probably need a targeted and holistic approach, but for sepsis survivors or patients and families, already the acknowledgement of the post-sepsis syndrome and the sepsis sequelae, the damages that may come as a result, it would be the first step that the government or the organization would send and say, we care about you, we will hold you or we'll catch you, and let's, you know, observe and let's come up with a holistic approach which matters to you or to me or to the family. So.
Shasha, you're helping GSA right now and also, you know, advocating for around sepsis issues, both on the EU and WHO level. What role do you think the sepsis patients play in the battle against sepsis? You know what I'm saying? I mean, what can your stories sort of, how can they help in the getting the message across?
I think that sepsis survivors obviously play a big role in the battle. Why? Because we give sepsis a face. My perception is that sepsis is often spoken about in numbers or economic burden or deaths, but behind each and every number is a person who has loved ones, who has hopes and dreams and a belief in the future. And every survivor has their own story, right? And their own ending. Mine, I would say, is a happy ending because I'm here, I'm functional, I'm capable of telling my story, maybe as a cautionary tale, but also as a reminder that sepsis can happen to anyone and that it can happen anywhere, even in high-income countries.
I was thinking maybe, Ron, as a comment from what Anne was talking about earlier, how do you see sort of that connection? How can we learn from cancer management? Have you any comments on that? I'm just interested to.
Yeah, we were reflecting on this privately earlier, a couple of us, and I think there's a big difference between sepsis and cancer in that when someone develops sepsis, they are often delirious or unconscious during a lot of their inpatient stay. They're not able to advocate significantly for themselves. And when they leave ITU, they're not being looked after by a sepsis specialist. They're on whichever ward in whichever area of the hospital. Whereas a cancer patient forms a direct and lasting relationship with the health professionals looking after them. And so I think it's in many ways easier to raise advocacy around cancer than it is for an acute and chaotic and horrific condition like sepsis. But yeah, absolutely, we've got to learn lessons. I think for the non-clinical people, we have to remember that cancer's fight started in the 1960s and sepsis fight started well into the 1990s. So we have had less of a lead time into this. We've got to engage the public, the media, and policymakers. That's where we're going to make the difference. It's, yes, we need academia, yes, we need professional societies, but this is around public will. And if we get that bit right through spokespeople like I'm privileged to be surrounded by now, then we will affect change.
Yeah, perfect. I'm just wondering, we have about 10 minutes left here. So if you have any questions from the audience, and I was wondering, Marvin, we can start with Konrad. Marvin, is there anyone online that wants... Do you have... Start with Konrad.
Just...
All our money is raised by people that are affected themselves or have family that is affected by cancer. So they're all what is called the Flemish term actievoerders. So people that organize something to raise money, and they give the money to us. And so we raise each year. So last year we had 47 million. Money by the people that do care about their family and themselves, but most of the time it's because a relative got ill, and as also with sepsis, but also with cancer, almost everybody knows somebody who has cancer, and that's how we got the money. And of course, we also show each time how the money is spent. That's very, very important, and we spend it to research, but we also spend it to providing information, for example. We also do a lot of advocacy. So we are very transparent on how the money is spent, but we don't get any money from the government. And that is also an advantage, because then we can ask from the government.
Other, yeah, that's the one.
That was very touching. I will ask you, Ms. Kiavage, is there what transmit the information that you feel very sick?
I just want to make sure that I understood the question. You mean like if because Swedish is not my native language, or?
Yeah, because you are. If I could understand, you are coming from Iran.
Yes,
Iran,
that is correct. Yes.
And you are in Swedish, and it's. I think, from my experience, it's very much more difficult to understand, for instance, feeling on what was true or not true on the transmission. There was none non-official difficulty for communication?
Right. Well, that is a good question to ask, and I think it's very valid. But in my case, I have been living in Sweden since I was 5 years old, so it's kind of my native language. So no language barriers there. I was very clear.
Short story on that question. I was recently contacted by 2 doctors, medical doctors, who lost their young son at the age of 1 in a major teaching hospital near me to sepsis. We know from UK data that people in households of Pakistani ancestry have a 2.7 times higher risk of death from sepsis than children of British ancestry. And I asked that family, why did they not listen to you? You're both doctors. And they said, if we had had English as a first language, our son would still be here today. They didn't listen to us because we were from a Pakistani family.
Oh, that is so sad.
In culture, I remember Pakistan people who have broken his leg, and he was open, and he do not cry, he do not suffer, and well, the churches remain the things in place, and well, the cultural expression of the pain is not the same, even if the language is correct. The cultural transmission is something very difficult.
Yeah. We have a question over here, Simona.
Thank you. Hi, my name is Emily Vinolo. I'm an alliance manager. So basically my job is to set up and coordinate research alliances between hospitals, academic labs, and the biotech or pharma world. And I wanted to ask the question already this morning. We haven't mentioned pharma or biotech a single time since this morning. And your keyword this morning was collaborate. So where do you see the industry in all of this? We know that in cancer, advocacy is really important also in drug development. So a pharma company or biotech cannot avoid patient advocates anymore when when developing a new drug. What shall we do in sepsis?
Would you like to answer one, or maybe two?
Yeah, I mean, I can start. I think it's critical that we have a healthier working relationship with industry. I think we have to be conscious that health professionals can be sceptical of industry involvement, and therefore what we did with the Infection Management Coalition is we said this has to be funded by industry because we don't have the money for this. But what we're going to do is have a cross-section of pharmaceutical companies, medical equipment companies, diagnostics companies, and bring the industry regulators in. And to come back to my keyword, collaborate, it's that collaboration and making sure that the involvement of industry is healthy and balanced that can really make this difference, as well as the commissioning aspects and governments making it easier for those companies to recoup their investment.
Would you like to add something, Anne?
Well, I think now I'm working in a non-governmental organization, and we always avoid collaboration with pharmaceutical industry because we put the patient first, and we really do that. We listen to the patient. We try to help the patient as much as possible. And although the pharmaceutical companies often say they also put the patient central, they often are driven by money, by profit, by making profit. That's also their existence, making profit. But as a pharmacist, because by education I'm a pharmacist and I worked in, I trained a lot of pharmacists, then of course if you can collaborate with the industry, they have much more money and they can provide you with money. And the thing is, if you get them interested in investing in this disease or investing in tools to create awareness and to create a better diagnosis or to create tools for personalized medicine, yeah, why not? So, but it's always as now in the position in which I'm now, we don't work with them, but yeah, it's double. Huh? I don't know if you want to.
One more quick question. We have to wrap it up soon, but Simone, can you?
Okay. I think you recognize that some problems like neurocognitive sequelae are often framed as psychologic problems, mental problems. So how could we address this in a better way, you think? Do you have some advice for us?
Well, I think the better understanding of the disease, also it's a very complex disease, and the better registry of all the complications and all the post-treatment effects, that definitely will help you in getting recognition on of the symptoms and of this side effects. Because also in the treatment of cancer, a lot of patients suffer from side effects even 10 years after the treatment. They have a chemo brain, what it's called. They forget things, and that's only a few things. There are also fatigue is also a very common complication or side effect which can last for 20 years, in my opinion. So, but yeah, probably it all starts with a good registry, not only on the diagnosis, but also on the treatment, which type of treatment, and also on the complications and on the post-treatment symptoms. I don't know if you want to comment.
Yeah, I'd only add that yes, I totally agree that neurocognitive sequelae are common and can be mistaken for psychological sequelae. We have to remember that the number of neurocognitive rehabilitation specialists in any one country is probably measurable on two hands, and it's really difficult to understand what the impact of labelling it as neurocognitive sequelae will be without the resource to address it and to treat it properly. I think this needs positive role models. So people like, again, those around me, particularly sort of role models who move into the influencer space like Jashi has. And I've recently spoken to, we've got an old pop group in the UK called Westlife, who are still fairly big, but they were big 20 years ago. One of their group, I spoke to him last week, has not been able to go on their world tour because he's still struggling with the neurocognitive and fatigue sequelae of sepsis. He's now agreed to become a spokesperson for post-sepsis syndrome, and it's getting people like that on side that will make the difference.
Perfect. We have to go on now, but I'd like to give you all the opportunity to just give me 2 short sentences. What is your dream when it comes to, not a word, you get 2 sentences here. I'm a little bit more, I don't know. Anyway, when it comes to sepsis and the battle against sepsis, Jashi, you may start.
Thank you. My dream is for policymakers and decision makers to see the importance of battling sepsis, because no one should lose their life or be permanently affected due to negligence, lack of knowledge, or lack of preparedness. Thank you.
Point taken. Ulrika. Yes.
I would like to empower families and, hopefully not future patients, to stand up, to defend, no complacency. Sepsis is the most preventable cause of death and disability.
Okay. Yeah, here the ambition is to create awareness and to provide a better treatment and post-treatment for all these patients.
My first is a world free of avoidable harm from sepsis. My second is for sepsis and infection management to be afforded the same attention and resource as cancer.
Perfect. Well, that's a wrap. Thank you all. Thank you all. Okay. We have one more panel to go, and Konrad will situate himself here. He's going to be the moderator, and I'm going to leave the introduction of the panelists to you. But I think, where do we have Marco? Is he here?
Yeah.
Where? Oh, he's there. Oh, I'm sorry. I thought he was here. Okay. Before we start the panel, we have a talk, drug approval during pandemic, the challenge, and Marco here, Cavaleri, who is chairman of the COVID Emergency Task Force and head of health threats and vaccines development at European Medicine Agency. Marco, please, I don't know if you can see us, but we hear you, so please take it away.
Thank you very much, and apologies I cannot be there with you. I hope you can see my slides. Can you see them?
Yes, we can see them.
Very good. Okay, so I will start by talking, indeed, going through the experience of the pandemic, but also to take the lesson learned and what we may have to do in the future. So let's start by saying that indeed the COVID-19 pandemic has been something unprecedented in terms of the public health challenge, as you all know, but for the EMA is also highlighted aspects and areas that before we had never been really brought up to the forefront, or at least we had somehow a more refined role. While during the pandemic, really the role of the EMA as the European regulatory body has came out very strongly as being one of the key institutions to support the rollout of vaccines and therapeutics to tackle the pandemic. And I will start by saying that we were in a way prepared because we had an health threat plan that was agreed just a year before the pandemic. And this was taking into account the lesson learned throughout a number of epidemics and actually coming from the pandemic with influenza in 2009, but then also seeing the continuous emergence of new threats, starting from Ebola in Western Africa 2014, 2015, and then, Zika, and then Nipah. And then we had chikungunya, dengue spreading all over the globe, and now then with this coronavirus. So before that, we had really in place a plan, establishing a pandemic task force and a way of dealing also with shortages of medicine, which, as you know, particularly at the beginning of the COVID-19 pandemic, has been quite a considerable problem. And indeed, on the medicine shortages, this is an area in which EMA has been developing throughout the pandemic. And in particular, if you remember, in the ICU, there were problems with the availability of some medicine at the beginning of the pandemic. This is also because a lot of manufacturers are not established anymore in the European Union. So we have to resort from drugs that might be coming from the Far East. And of course, in a situation such as a pandemic, this has become quite of an hurdle. And then the other important area is that indeed, particularly through the emergency task force, we were exposed to a number of aspects that are beyond, the pure regulatory role that we have in authorizing medicine once a manufacturer from industry will come to meet to us a file for approval. So we had also to go out making recommendations for repurposed agents, discuss how to design clinical trials in which maybe industry was not involved, and coming out with a recommendation on how to use the vaccines, for example, which is normally something done by the public health authorities in the member states. And all of this has been concluded with a new regulation that entered into force during the pandemic, or at least while the pandemic was still ongoing, in which extended the mandate of EMA to cover precisely for these two big areas, so medicine shortages on one side, and the other way, the ability of going through rapidly evidence review and making recommendation in the context of an emergency and see how fast we can be in developing therapeutics and vaccines. And the emergency task force has played a pivotal role indeed for development of vaccines and therapeutics. We have started from even before it was declared a public health emergency of international concern in working with developers, contacting companies, contacting whoever had an intention of running a clinical trials at the moment. At that time, antivirals were the main focus. But then, as you know, the focus has been extended. And this has been done in a very proactive way. And you see here a few numbers with more than 250 plenary during the pandemic of the emergency task force, we discussed 270 therapeutics and 80 vaccines. So the amount of data and information that we had to process and come up with an advice in order to support rapid advancement of medical countermeasure has been quite intense and immense, I have to say. You see at the bottom of the slide the key 3 areas where the emergency task force is working on. So really giving scientific advice to developers, which is industry, but also sometimes academic consortia. Several times during the pandemic, we ended up giving advice to consortia of different academic center, clinical trial networks, in helping them in designing their clinical trials in order to generate evidence that could trigger regulatory decisions. And then doing this systematic review of all the evidence in order to come up with ETF recommendation, which can be also medicine that are not yet authorized, but that we think, could still be recommended for use even before a proper market authorization, or maybe not authorized. And this, again, is also in the broader spectrum of how to use medicines and vaccine in the context of the pandemic. I've already been speaking about the early support to COVID-19 developers, which has been instrumental to allow medicines, so antivirals at the beginning and then vaccines later on, and then other immunomodulator agents to be approved in a timely fashion. This approval goes through the system that is called rolling review, which means that instead of generating all the data, and then once you have completed all the data that are needed for a market authorization, submit to regulators, submit them as they become available piece by piece, so that by the time the last piece is submitted, regulators, the EMA is ready to go with an approval in a matter of few days. That's the concept of the rolling review. It worked very well, but of course it's extremely time intensive because you need to spend a lot of time and to have assessor readily available to look into any new evidence that is emerging and get submitted to us. And there were other aspects in terms also of procedural flexibility that were very important, like the labeling, the use of remote inspections, for example. But I don't think in the interest of time, I will go into that despite their relevance. And this is just a snapshot. I will not enter into the details of all the vaccines that we have been approving and the therapeutics. You see on the left the vaccines, starting from the first one that were authorized. So the EMA authorized 8 COVID-19 vaccines. So probably the agency in the world that authorized the highest amount of vaccines. And as you know, we also approve now a number of adaptive vaccines, so adaptation of the vaccines that were initially authorized, also as booster doses, and we're still doing some work. So there are still some vaccines under evaluation. And of course, also on the therapeutic side, a lot of work has been done, particularly on antiviral, as expected, but also said on immunomodulator agents. And here again, the EMA played an important role. For example, here, dexamethasone is not quoted, but the review of the EMA on dexamethasone helped the authorization of this product, which was already approved for other indications, as you well know, in all the European member states. But the EMA review was very important in allow a fast process for authorization at the national level. And not to forget the international framework. So the EMA has never worked in isolation during the pandemic, and even now is not working in isolation at all. On the contrary, try to work together with other regulators in the world. One of these platforms is called ICMRA, which is the International Coalition of Medicines Regulatory Authorities, bring together regulators from all the continents in the world, even if it's not comprehensive of all the United Nations member states, but nevertheless gives a good profile of agencies all over the world. And here we work in a collegial way with regulators from other regions in order to come up with consensus and agreement on how to approach vaccines and therapeutics, how to design clinical trials for vaccines and therapeutics, and how to assess them. And here on this slide, you see quoted the report of a meeting that we had on endpoints for clinical trials for therapeutics, for COVID-19 therapeutics. And that has been extremely important because in this way, we agreed all over the world on what would have been the primary endpoint that would be required for approving a new treatment for COVID-19. And as said, we also came up with a number of recommendations that were beside the formal regulatory approvals. These were done throughout the pandemic. And I always quote this one because I think it's extremely relevant, as the EMA has been the only agency in the world that came out loud and clear in May 2020 when there were some politicians in the world that were claiming that hydroxychloroquine was the solution to the pandemic, in warning everybody in not to use hydroxychloroquine except in the context of randomized clinical trials, because that was the only way to really understand if this agent was effective in treating COVID-19. As you all know, it ended up showing that this agent is not effective in this sense. And therefore, it's important also this role in terms of communication to prescriber, to physicians, to the general population about the knowledge, the evidence, and what should be done in a context such as a pandemic. And very few words on a number of studies that we have been assessing. This is the only study that gave positive results for a monoclonal antibodies with antiviral properties in patients that were already hospitalized, so with a more severe spectrum of COVID-19. And 2 points I want to highlight here. First of all, that there is now an increased interest in this type of simple randomized clinical trials in which you recruit a broad population without too many inclusion-exclusion criteria and without too many data collection throughout the study, which is something that, as you know, also the FDA has expressed interest on. And also from our side, we are looking at how this type of designs could be used in the future, and particularly in emergencies, to collect important evidence still in a randomized fashion around the utility of different therapeutics. But also, it's important not to forget that even if you go with a simple study, there are some important aspects in the recruitment that have to be considered. And you see on this slide that if serostatus at baseline was not collected, the study wouldn't have ended up as a negative study, because if you include all participants, there was no difference between the usual care, so the control arm versus the arm in which this monoclonal antibody was included. But when you look into serostatus, and so data on serostatus were collected at baseline, there where you see where this agent is useful. So as always, there is a need of fine trade-off between the information that you can skip and the information that is still are vital in order to allow you to interpret the results of your clinical trial, even in the context of the emergencies and even in the context of simple, pragmatic, randomized clinical trials. Well, as you know, one of the other challenges that we had in the pandemic is the fact that the virus started to mutate very rapidly. This, of course, caused a lot of problems. We had to adapt the vaccine, but also quite astonishingly, it had a huge impact on the activity of these antiviral monoclonals that were so effective in the treatment and the prevention of COVID-19. And with the emergence of this variant, and you see here on the left, essentially all these excellent monoclonal antibodies were lost because simply they didn't have the ability anymore to neutralize the new variants that were in circulation. On the right, you see the data on the small molecules. So the small molecule, differently from these monoclonal antibodies that really neutralize the virus by binding to the spike protein, which is the part that is mutating constantly. These small molecules, they bind into polymerase or the protease, so other proteins in the virus that are less prone to mutations. And therefore, they retained activities throughout all the different variants, and they're still active nowadays. So it's important to look at different agents, considering also this aspect of viruses, they change over time. And a word on the approval of anakinra. DMA approved anakinra, but what I want to stress here more than anakinra per se is the fact that this development program was conducted using a specific biomarker for inclusion of patients that had bad prognosis in terms of outcome, including mortality after COVID-19. And therefore, in this study, they used successfully this biomarker that is called the SUPAR as the basis for then coming up with the demonstration of efficacy of anakinra in an enriched population based on this biomarker. And so we think it's very important that we should continue this type of work, that we think about using particularly immunomodulatory agents in the context of ARDS or sepsis, viral sepsis, or other type of sepsis using specific biomarkers, as that probably is the best approach that we can do in order to understand, based also on the mechanism of action of the agent under consideration, what could be the population in which a positive benefit risk can be demonstrated, and indeed how to best use this type of products. And then a few words about the fact that indeed, the pandemic is also very dynamic in terms of the burden of disease, what is happening, and also what is the efficacy of the different interventions. So we should not forget that dexamethasone really demonstrated in the recovery study a quite significant impact on mortality. But the question is, would corticosteroid have the same effect today, considering how much the virus has been mutating, and in particularly how much the background immunity in the population has been changing, with this being much more present than what was in the past. And you see here a study that tried to put together all the data available with corticosteroids and really indicated that when mortality tends to be lower, then dexamethasone could even have a detrimental effect. So it's very important that we continue to investigate what is the impact of this type of intervention against COVID-19, but also other type of viral ARDS, so that we better understand how to use this medicine. So the data collected at a single point in time might not be sufficient to give us a perspective in the longer term. And of course, corticosteroids have already been tested in few studies, not a lot, I have to say, so we need more confirmatory work here in the context of severe influenza, but the evidence that we have so far are not indicating really an effect of corticosteroids for severe influenza, even if there are a number of pitfalls in this study, so it's very difficult to be conclusive here, and we look forward getting more data to really understand what is the impact of immunomodulators such as steroids in the context of other severe viral infection. And not forgetting that, again, what may happen in the seasonal setting, like for influenza, may be very different than what happens when you got pandemic influenza, or when individuals get infected with strains that are very far away from the immunity that is present seasonally. For example, like in this case for avian influenza, like H7N9, which really indicates that influenza might be much more severe, and also the inflammatory profile would be very different, which would indicate that in those circumstances, testing immunomodulatory agents will be really warranted. And taking stock of all the learning that we have through COVID-19, and now we are revising our guideline on investigation of medicinal products in the treatment of patients with acute respiratory distress syndrome. And of course, one of the basic questions is what we're going to do in the future. Are we going to require studies only with a single etiology, for example, COVID-19, or maybe merging etiologies, including other viral infections, severe infections such as flu, and whether this will be warranted or not. And of course, it's not a straightforward type of discussion, also because the scientific evidence is limited, but we should not forget that we might not have the same bucket of patients that we had readily available during COVID-19 pandemic with these type of profiles. So more work will have to be done in making sure that we are doing the right studies and collecting the right evidence, including what I mentioned before on the role of biomarkers and exploring biomarkers. And the same will be said also in the context of clinical trials for sepsis. And maybe the last point I want to touch upon is the fact that we also had a lesson learned after the pandemic about conduction of clinical trials in the European Union. And really, we have to admit, not only during COVID-19, but also afterwards, where Mpox outbreak occurred, that in Europe, we are extremely slow in launching multinational clinical trials. We saw really a massive fragmentation of clinical research with duplication of efforts and underpowered study, leading all to inconclusive results. So there is a need to try to think about how to merge all the efforts and doing better in the future, and particularly in preparation for emergencies. The approval timelines were very slow, particularly for multinational clinical trials. And actually, when it takes more than 3 months to start a clinical trials in the midst of a pandemic such as COVID-19, you really think that we need to do better. And we really need to think how to create a more suitable regulatory environment for allowing this study to start as soon as possible. Also, some aspects, for example, the sequential submission across different countries with delays, and then country by country requirement with continuous resubmission. This also is something that we need to tackle. We need to do better. And of course, very importantly, there are being discrepancies among regulators about how, key aspects of the study design. And here we are working for the emergency task force to make sure that in the future we will be doing better. We will find good way of collaborating with regulators in the European Union national level, since approval of clinical trials is still in the remit of the national competent authorities, but also more internationally and globally, I would say, and through WHO. And therefore, we had a workshop like last year at the EMA, and we discussed a number of aspects that now have been embedded into actions, which include like the setup of a EU-level cooperation mechanism between ethics committee open to all member states. In the actual fact, we discovered that ethics committee don't talk to each other, don't talk not only nationally, but internationally. And therefore, we need to find a place and a forum to allow more discussion and alignment across ethics committee. The concept of trying to solve problems before the actual submission, and now with the clinical trial regulation in Europe, you have to go through the CITES process. So the more you can solve problems in pre-submission meeting and in specific consultation, the better it's going to be. The ETF will remain with its role as the central hub for discussing the scientific aspect of the protocol, and we will include in the future also ethics committee and members from the national competent authorities. And then the system for submission for CITES will have to be improved, and DMA is working on that. And very briefly, also, we are working with ERA, which, as you know, is a new entity created in the European Union to foster development of medical countermeasures to tackle emergencies. One important point that we agreed upon is the creation of a coordinating committee that would decide which products should be prioritized for clinical trials, which clinical trials network should be used, and which study design in the context of an emergency, but also working in the inter-epidemic period so that we got a good layout of what can be done, how to keep the clinical trial network warm-based, and what kind of evidence should be generated in between different emergencies. And the last point is indeed that the EMA and the heads of medicine agencies across Europe launched this accelerating clinical trial, which is called ACT-EU, really to transform the EU clinical research environment. And a number of priority actions have been identified. I will flag here the one at the far right, which is really clinical trials in public health emergencies. We will be working in increasing collaboration across ethics committee with expertise and experience in this area, creating a fit-for-purpose regulatory flexibility and a really basic package for clinical trial application during public health emergency that would allow rapid approval of these clinical trials. So we need to take stock of the lesson learned of COVID-19 and find way of getting better medicine to patients faster. So need to generate the evidence to inform use of medical countermeasure as soon as the emergencies arises, because the window of opportunities can be rather short-lived. And we need bigger, better, and faster clinical trials. So the concept is having protocols and arrangement in place, empower coordinating body for rapid release of funds on the right study, right product, and right network. The ETF role in guiding the acceptance for regulatory decision and having rigor in the scientific definition of the clinical trial protocol. And all this, we think, is needed to be better prepared in the future and to tackle emergencies that will unavoidably come in the coming years. Thank you very much.
Thank you. Do you hear me? I am Konrad Reinhart and have the privilege to thank you so much for your comprehensive overview and on what really has been achieved and learned during this pandemic. I think always pandemics have really been driving force for societal but also primarily scientific progress, and the COVID-19 was definitely one, from my perspective, to overcome the notion which prevailed for the last 20 years that sepsis is the graveyard, the billion graveyard of the pharmaceutical industry. And we learned already that without industry, both in terms for developing better diagnostics and therapeutics, we will make no progress in any medical field. So thank you so much. And I think you have introduced yourself. I learned that you are an MD and a PhD. And Ferron, you stay with us. Thank you for this. It's my pleasure now to call my longtime friend first, Antonio Artigas, who has introduced himself already for another panel in Catalonia, and not only in terms of research, but also to introducing quality improvement, not only initiatives, but structural over all Catalonia to have this code sepsis, and who were one of the first ones who did this on a state level, and including also your work with the society, with the Surviving Sepsis campaign on several important research also. Moreover, our next long time great friend who also has done, and his work has been quoted and received emergency use authorization, also in this case of addressing sepsis by COVID or severe infections and sepsis by COVID with personalized approaches. As a founder of the Hellenic Sepsis Society, has done so much great works, including that based on his meta-analysis, we could prove that really most of the patients with severe sepsis fulfill all the criteria of sepsis, and this is now a very much quoted study. So Adam was Linda, also is a long-term friend, and both of them are also member, and as Antonio, not only of the steering committee, but also of the sepsis research group, because ASA has not only a patient and family group, and I hopefully an even increasing research group from the University of Lund, and we owe him also much, not only on the understanding of his work jointly with Lisa Melhammer, to have patient record-based data. And this is our problem, that health record, that administrative data, that we have just published this for Germany, and this is known also from the US, we will get only 1/3 of all true sepsis cases which are really in the health records. And the future for this is, if we would have digitalization in all places, so we had a lot of access. But I stop here now, and just to, with this introduction, and with some, with some questions to you, because we have not all the time to address all issues. But if I would start with the same question that have been addressed all the panelists from the former sessions, what would be, Adam, your ideal situation, how to move forward with the research in this, let us stick both epidemiology, which is key to convince policymakers on the burden of sepsis, but also how we can come to better diagnostics for patient use, and also for doing clinical studies with innovative therapies. Yes.
Yeah. Yeah, that's a very interesting question. I think we have been. It is quite hard to create networks and research between countries, actually. So I think one way would be to try and increase the research effort within a country, because data is not always transferable. I mean, you have different situations with the AMR situations. In Germany, you have maybe 10 times more ICU beds than in Sweden. So it's a lot of different things there that also that I think that I should encourage different countries to create their or increase their efforts to create infrastructures for research within the country, so that each country have high quality data, and then you can try and compare it and validate it in other settings, other countries. So that would be what first came to my mind.
Evangelos.
Well, thank you very much for your kind words and your nice introduction. I believe that we are moving to a future where the scientific society, I don't know about the industry, but I believe that scientists and physicians are convinced that several patients who look the same, they are different in the prevailing mechanism in their body. And so treatment needs to be addressed against the mechanism, which means that there are, of course, very fancy, I would dare to say, technological improvements in terms of omics technologies, but the problems of the omics technologies is that, first of all, they are extremely expensive, and second, they take a lot of time until you get a result. So the aim is to identify specific biomarkers which can suggest which is the prevailing mechanism. The problem there, I believe, before moving into the industry and and also this is the experience that we had during the pandemic. For us who are in the field of research, it's easy to understand that because a biomarker is increased, you may use this as a selection tool of treatment. I'm not really convinced at that stage if the average treating physician is ready in terms of his background training and education and if he's convinced to address treatments just because there are endotypes and increased biomarkers. So I believe that this is something that research networks need to embrace, not only the qualified research centers, but also average physicians, so that they are ready, once the result comes out, to apply that to medical practice.
Antonio, your take?
I think everything was already commented, but I just would like to emphasize that the need to include non-physician basic investigators in these networks, because not just only to create a network on preclinical studies that can be then translated to the clinical practice, but also for some basic science mechanism that you need the input of from biophysics or from biologists, etc. And I think for the future, the networks on sepsis should include physicians and non-physicians experts on investigation as a multidisciplinary approach. The second comment is that I mean, a network is absolutely necessary in Europe. We are in Europe. We are not, in the United States. I'm from Catalonia, but I feel to be in Europe, And if we want to be competitive with United States, we need to create something strong and competitive with the American groups, and probably to try to share or to, to define different or the same objectives. But I think this is the only way to move, as Evangelos mentioned previously, to move for a more personalized medicine. If you look on the different randomized controlled trials, therapeutic trials, it was a disaster. We invest a lot of money, and the results are ridiculous. So I think I learned a lot from the ARDS network. They were able to work in a network and defining the personalized treatment, defining the two phenotypes. And the treatment should be adapted to this in the future randomized controlled trials. And also, I learned a lot of the patients, the measure of guidelines and recommendations are for the time zero, but the patients are, there is an evolution. So the time, and to define the time of the sepsis start and the evolution during the first 3 days, treatment are not the same. So, and the subphenotypes, and we did recently a study about this, the subphenotypes in time zero is changed enormously in time 3. That means that you can do this if you have a strong network on sepsis. And we need this in Europe.
Thank you. Dr. Cavaleri, just if you shortly summarize your lessons, you said bigger, better, faster. How do you see the way to get there? Because we have been, in comparison again to the US, slower, less effective, etc., etc. And perhaps you can also address, because you mentioned harder in comparison also to BARTA, where we also had, I think, a 5-year delay to set this up. So, but what from your perspective is a key lesson to really get better? You have mentioned some problems, but how to overcome them? You are muted, perhaps.
Oh, am I muted?
Yeah, now you can hear. We can hear you.
No, I think indeed, as said, it's difficult to see why we always have to come after the United States or other regions in the world, or even the UK. Europe has been slower than the UK. And Europe is an entire continent, so there are plenty of patients and plenty of really excellent centers. So the question here is that we need really with ERA, with the funds coming from the center, so from the European Commission, but also the funds that are in the member state, to have a place where all this can be discussed together and really set an agenda that would allow us to create this clinical trial network that will be able to conduct studies in peacetime, so in the inter-epidemic period. And as you know, there are plenty of open questions and plenty of patients anyway that need to be treated with sepsis or ARDS. And so really to create these clinical trial networks, and it would be good that these clinical trial networks are really going beyond the border of each individual member state, because we need to really take full advantage of the fact that Europe is a big continent and has many countries, and we don't know exactly whether next epidemics, whether there will be one country hit more than another. So we need really to have international networks, but these networks have to be set up now. We should not wait for an emergency to come, and we should find a good way of funding them so that they can run research continuously and address a number of very important scientific questions. The patient phenotype, the biomarkers, how to approach them, what kind of agent to use in which status of the patient, and understanding that this is very dynamic. This is something that we start working on right now, so that when the next emergency will come, we will be better prepared. And also we will answer a lot of questions that will affect the daily life of anybody that is working in the ICU. So really, I think we should take stock of this and make sure that we create a clinical trial networks that are able to deliver here, starting from now, starting recruiting the patients that are available now, and start to understand what kind of agents will be useful and which one or not, depending indeed on the phenotype and the characteristic of the patient, because this is a word that indeed we still need to explore fully. We still need to get full understanding, and we still need to get full understanding indeed of which drugs will be effective and which not. So definitely through ERA, the Commission and the member states, now we are trying to launch this type of approach. And I believe that, ICU specialists working on ARDS and sepsis have to be fully involved in this, because the reality that we've seen during the COVID-19 pandemic is that these were really the crucial area where we could save lives. And so it's very important that we do not forget that in the next pandemic, there will still be a lot of patients going into the ICU with, respiratory failures or organ failure. And we need to think about that, and we need to think how to be better prepared. So all I can say is that from an EMA perspective, we'll be encouraging European institutions and member states to collaborate. And the creation of this coordinating committee is a first step to make sure that we have a place where member states and funders in the member states and in the Commission are coming together. And with the true expert, we decide which clinical trials networks are worth funding, what kind of products should be studied, and therefore, move on with an agenda that will bring up Europe in its ability of delivering evidence and clinical trial data that are so important for treating patients. And I understand, and I agree with the comments made before, that it's difficult to see why Europe is not at the forefront here.
Not sure whether you have heard this discussion this morning, where I have made the point that the burden of sepsis compared to AMR is 50 times higher than the burden of AMR. And I just wonder how we can overcome this disproportionate perception, not only on the level of the policymakers, but also because if you compare the research money that currently goes into AMR research and activities, it's the same disproportion. And do you think, because given that any pandemic has its problem by developing and progressing infections to sepsis and multiple organ failure, do you think it will help, as you said, that it's badly needed, and this was one lesson from this Spanish flu pandemic, that you have to learn in this time, they called it pneumonia, in orderly time to be prepared in the time when the pandemic comes. So do you see a chance? Is a body like the EMA also able to convey this message where we so far mostly failed to convince and get the ears of our policymakers? So this question goes to you, but also to any other panelist, what you think, and also the audience, how we can get there.
Very briefly, from our side, we are very committed to do that. The emergency task force is really a hub to discuss also with academic consortia what can be done. And we always been flagging to the European Commission and to the member state the areas that we think are critical. And I completely agree with what you said, that we need to continue now in peacetime in creating a framework that could set up this clinical trial network for ARDS and sepsis. And also continue with the investigation of products. There are some products that are very interesting, but unfortunately, they came late during the pandemic. And so now the question is, what kind of study can we do in order to understand if they are efficacious or not? And the question is, can we merge COVID-19 with severe influenza? We really don't know, but we would really like to see efforts put in this direction so that networks are created, can also continue advancing our understanding of what treatment might be effective in viral ARDS and sepsis, and therefore, be better prepared for next pandemic, because first of all, we will have some products that we understand better, and then we have the clinical trial networks that could also investigate very rapidly any new product that might be emerging in time of crisis. So for both these reasons, we are extremely committed in playing our part. Of course, EMA is not a funder, but we can influence the entire system, the funding system in Europe, both at the Commission level and with the member states, so that we make sure that this is happening. And you may have noticed that BARDA also launched a call on ARDS, and we would like to see something similar also on the European side. So not to forget and not just focus on the pillar of antivirals and AMR, but to think also more broadly about this type of settings, because this will be extremely important from a public health perspective in future emergencies.
Thank you. And your perception, how to overcome this?
I think it's crucial. Yes. Yeah. I think it's crucial to have an excellent network of different centers working with the same protocols, the same standard care, etc., and the same quality. I think this is a key point and the major interest for the companies, that they want to have a good network to do or to test new treatments quickly and with a high quality, but also is key for the European organizations. I mean, the European Union, they will promote or will accept and support networks, good networks, through the COST program, other programs that will facilitate it, to do the trials as soon as possible with good quality. And also, another point that I think is very important is the training and education programs, exchanging investigators from one center to another, etc.
Perhaps you can also address, because regulations, you have mentioned ethical committees. You have, and there were situations where, for example, a country like Netherlands has already included in some trials within 3 weeks the patients, whereas in Germany it took half a year before the first university hospital was able to include a patient in a prospective trial. So how can we also, by European activities, make this clear that we have to overcome these kind of limitations?
Well, this is the daily frustration, which being also acting as a president of the Hellenic Institute for the Study of Sepsis, which is a non-profit CRO, I have to face. Indeed, there are a lot of delays in this, and you cannot push the ethics committees. You can push at a certain limit, because then you will be accused that you intervene in their independence. However, I believe that what is very important, and this is something that we experienced during COVID-19 and with the approval of anakinra, I was very happy that the impact of the sponsor, that means the industry, was limited. They offered the drug, they offered something very reasonable in terms of funding, and they were not involved in anything, not in the design, not in the execution of the trial, not in the interpretation. And I believe that this is an example that should also be for the next drugs, because in that way we know that the drugs were approved by the academic world with the high standards, and they were not impacted at all by the industry. What do you think, Arne?
Yeah, I think coming back to the AMR, and I think iterating that AMR would not be interesting if sepsis was not present. I mean, to try and communicate that, and eventually people will understand this. And coming back to the network, of course, European networks are extremely important, and I think the future is, we got the previous question regarding AI and the role of that in diagnostics, and I think that is the way forward. But to make use of this, we need very, very high quality data. And one idea could be, there are a lot of countries now launching different action plans. We heard about Switzerland, we have it in Sweden and other countries, and that could maybe be an opportunity to try and piggyback on that from the academic side, to try the countries that have an action plan in order to try and conform it so that so that we collect the same clinical data, and try and establish cohorts that actually are interpretable between the countries, because that is one problem. If you want to have an early biomarker, you cannot collect it in the ICU. It's too late. You need to collect it in the emergency department, and that is a different challenge. And for instance, in Sweden, only 7% of sepsis cases are actually treated in the ICU, so it's only a minor fraction. The majority is outside the ICU in intermediate care and general wards. So that is a challenge that we have.
We have not the time to discuss why Sweden does this with 7% of the ICU beds than in Germany and has half the mortality rate. So, but another important question is that, which I see, both from producers of diagnostics for sepsis, and also relates to AMR, because if we really want to overcome AMR, we must no longer treat patients with viral sepsis or viral infections with antibiotics. And this can be only achieved with better diagnostics. However, the reimbursement for these diagnostics is not foreseen in our healthcare systems. And it's also not foreseen in the DRG systems. And as long as we cannot convince our payers and our policymakers that the same is true with the development of new antimicrobials and antibiotics, so there's a societal need. And if we don't achieve that these developments at the end of the day will be remunerated adequately, industry will not go in these fields any longer. So that's another, I think, important issue that we must not forget. In cancer, this is quite different because there's much more advocacy and lobbying. So, but there was a question from your side.
It is very important to also look at the funding, and the funding in Europe is variable. You have healthcare, health insurance-based systems. You have systems that are funded through taxes, like I think in Sweden it's tax-based, in the Netherlands as well. So in those countries, the government has a lot more to say in terms of funding. Germany is health insurance-based, Belgium as well. And I think that's another stakeholder who should be sitting at the table is the insurance companies or funding bodies of healthcare, because they also have valuable data. And I think these data are underused in the planning in the policy making. Yeah. So I think that would be quite a valuable contribution to the discussion.
It's also very important. A last question from the audience, and we must take care not running out of time. Then I will have after your question a last round with the very best wish from the panelists.
For the diagnostic part, for troponin, it takes 10 years before troponin was accepted by cardiologists. So diagnostic takes time to be adopted by the community. And for the trials, there is bias by the industry because industry need to win money, but there is also bias from academic. And the best thing is to share the two both and say what the bias are.
Yeah, thank you. That's all important issues, and we keep them in mind and need to follow up. So your very best, with 2 sentences, wish how to promote research in Europe.
For me, it's multidisciplinary and sharing data from the different groups.
For me, it's commitment and enthusiasm and devotion and hard work, which unfortunately for sepsis takes 24 hours a day, because a sepsis patient does not obey the clock of daily work.
Yeah, I would like to have a high-quality European research network, and when it comes to clinical trials, I think the idea of having some kind of a European ethics a fast track would help a lot.
Dr. Cavaleri?
Yes, similar to the last comment, for me, setting up a robust clinical trial network across all the 27 member states of Europe and maybe beyond, including other countries in the continent, because this will allow to run protocols in the inter-epidemic period. And as said, sepsis and ARDS are anyway involved in both AMR and pandemic preparedness. So we need to have this ready, and this will allow also to engage more on the regulatory and ethics side to then enable a faster approval of clinical trials and a shared understanding of the importance of conducting these trials very rapidly during emergencies. And we at the EMA were happy to support any effort in this direction and discuss with the member states and the Commission how these clinical trials can be funded and supported.
Thank you so much. So now before I hand it over to our chair of the European Sepsis Alliance, I wanted to say that in contrast what I said very early when I talked on the situation, that the situation has not changed since 2018, when we had created or launched the European Sepsis Alliance, and I was very unsatisfied on some level and this was more to the European authorities to some degree, but having had this discussion and what we have discussed later on, I think we have definitely made a lot of progress over the last 6 years, and I think we can all be quite proud of it to have been contributed, including the many patient organizations and colleagues, etc., etc. So this is to say, and I hand over now to you, and yeah.
Say, before we put on Evangelos to take the final talk here, or final conclusions, I'd just like to thank you all for coming here today, especially those who have also been joining us online. Very glad that you all could join us. And now, Evangelos, if you can just sum up the day for us, please.
I would like to... I would like to thank you very much for being with us this whole day, and I am attending the meetings since the beginning of the European Sepsis Alliance, and I'm really glad and satisfied that I see an audience with enthusiasm. It's the first time where there was such an interaction, and I see this improvement, quality, I would dare to say, improvement in us, interior quality improvement over the years. I'm enthusiastic, as I said at the very beginning, the welcoming note, that we all share the same vision, that we work together not for us and for our self-recognition, but for our patients. And I remember, and when I was a fellow, that, the advantage of being a fellow is that you have one-on-one interaction with your patient, one physician, one patient. And then all of a sudden, if he turns well, he looks at you and you feel satisfied. And now we are at a level where we cannot share the satisfaction. We vision the satisfaction because we work all together united for our unknown patients. And this requires that there is a vision which is guiding us. And today I feel certain that we share this common vision, and I'd like to thank you very much for this. Have a great day. Also, I apologize for this and for Emotion. I would like to thank all the supporting team from the Global Sepsis Alliance and the ESA who are supporting us. How many years now, Marvin? 8 years. And also, could you also tell us the total number of those who participated online?
More than, no, not yet.
Well, not yet, okay. Okay, this is really great, more than 400. And actually, I would like to pay a special thanks to Simone Mancini, who over all these years, he's keeping us united in the steering committee. And it is thanks to his belief on us and his sustaining my daily pushing and several daily fights that we may have this wonderful result. And I'll thank him once more wholeheartedly. Ulrika for her full coordination and also for pushing us, and I'm certain that the year to come we will manage to have her dream and her vision, which is the financial burden of sepsis, to make this a reality. Thank you very much.